We are live.
A very good, bright, and sunny good morning to all, and welcome to AIR's Guru Sangam, the session 10, which is on glaucoma and trauma. This is the 2025-2026 edition of Educate, Elevate, and Excel. And we thank our AOS dignitaries for making this, organizing this entire session. Dr. Partha Biswasa, President, Dr. Santosh Navasa, Honorary General Secretary, and Dr. Manoj Chandamathur, Honorary Treasurer. The speakers for today who have consented to be a part of it despite it being a Sunday morning are Dr. Purvi Bhagat, M&J Western Institute, Regional Institute of Ophthalmology, Ahmedabad, Dr. Monica Arora, Sitapurai Hospital, Dr. Teki Dodum Dara, Sri Shankadeva Netralaya, Guwahati, Dr. Charita Manke, Hindu Hriday Samrat Balasaheb, Thakre Medical College, Mumbai, and Dr. B. Vijay Lakshmi, Government Medical College, Narayanpet. We have our expert panelists who have joined us to help out with the discussions. Dr. Bhavna Sharma ma'am from AIMS Bhopal, Dr. Satyen sir from Satyen Eye Center, Eye Care Coimbatore, Dr. Sher Shah from Drashti Netralaya Dahod, Dr. Vanita Patakre from Center for Sight Hyderabad. I welcome you all, and the topics that we will be discussing today will be ranging all the way from trabeculectomy, MIGS, glaucoma drainage devices, approach to a case of ophthalmic trauma, triage in any situation, management of open globe injuries. And the moderator, my co-moderator will be Dr. Prasanna Venkatesh Ramesh from Mahatma Eye Hospital, Trichy, and myself, Dr. Roleka from Mahatma Gandhi Medical College, Jaipur. So, a very warm welcome to all of you. And may I now request, just a second, I'll unshare my screen. May I now request Dr. Purvi ma'am to please share her screen and walk us through learning trabeculectomy step by step. Over to you, ma'am.
Yeah, thank you, Dr. Rolika. And it's a pleasure being part of this Guru Sangam series. So I'll be talking on how to perform a good trabeculectomy step by step. There are no conflicts of interest in this presentation except academic. So a success in trabeculectomy is very, very unpredictable and it is unguaranteed. And it is very unlike cataract surgery where you can almost guarantee a good visual acuity and quality of vision on the next day. Here complications are bound to happen, are likely to happen, and it's full of surprises no matter how skilled a surgery you may be able to perform. So it's all about preventive measures being taken and certain precautionary measures that being taken, and it mainly comprises of certain do's and don'ts starting from the preoperative period going up to the postoperative period. So in the preoperative period, the first thing that we need to check for is what is the demography of the patient, what is the type of glaucoma and the severity of glaucoma, and very importantly, what is the status and health of the ocular surface. Because all these factors will determine if you need to modify your surgery, if you need to take any additional precautionary measures to increase the success rate, and also to decide whether you need to use an anti-metabolite, which and in how much concentration and in what strategy. Regarding the ocular surface, you need to see for the inflammation because many of these patients are on long-term topical drugs. They might be having a pre-existing ocular surface disease. There could be scarring because of a disease or because of a prior surgery. So all this again has to be taken care of and dealt with before you actually go on to perform a trabeculectomy. Before the surgery, you need to withdraw certain high-risk drugs. High risk as in those which are likely to increase the risk of failure because some of the anti-glaucoma drugs are pro-inflammatory like the prostaglandin analogs, pilocarpine, even brimonidine which is known to cause ocular surface diseases, and now even the Rho kinase inhibitors because a significant amount of hyperemia and there is increased vascularity of the surface. So all these drugs need to be withdrawn within a reasonable amount of time. While you're withdrawing these drugs, always remember that they should be replaced with a systemic drug for that interim period because the pre-op IOP should be as low as possible. If needed, you can even use injection mannitol in the preoperative period because we don't want to operate under conditions of high IOP, which can lead to complications like choroidals and hemorrhages or expulsives. If the ocular surface is found to be very inflamed and unhealthy, you can even start topical steroids. The most common steroids are the soft ones, the fluoromethanol or the loteprednol, if needed, so as to control that inflammation. If the patient is on blood thinners for any reason, they need to be discontinued, but always in consultation with the treating physician or the treating cardiologist and with an appropriate documentation. And of course, as for any other intraocular surgery, you need to do a thorough ocular evaluation and again a good fresh baseline glaucoma evaluation. So surgery would work well only if it is done reasonably well. So what we now follow is known as the Moorfield's safe surgery system. So the first change that has been done is we have practically switched over to from a superior rectus brittle suture to a corneal fixation suture. Because in the superior rectal suture, it has been found that it causes muscle damage, it causes conjunctival buttonholes, lot of necessary conjunctival manipulation. Sometimes there can be hematomas, all of which can sometimes interfere with the success of a trabeculectomy. So we now use the corneal fixation suture, wherein a 6-0 vicryl suture on a spatulated needle is passed through the clear corneas for a distance of about 3 to 4 mm and half the thickness of the cornea. So as you can see, it gives a good amount of exposure, but the care here needs to be taken that it should not be too deep. Otherwise, you can perforate the cornea and enter into the anterior chamber, causing hypotony right at the very first step. Or it should not be too superficial also, otherwise it can cause cheese wiring. Sometimes if this bite is, just a second. So sometimes if this bite is very small, then you can take an additional corneal fixation and second one by the side. So you can have two corneal fixations side by side to give a good exposure. The conjunctival dissection, it can be again fornix based or limbus based, but with the limbus base over time, it has been found that it causes a posterior scarring, which is known as the wound of steel formation here at the posterior edge. So all that aqueous is limited from going posteriorly and it tends to go anteriorly over the limbus and over the cornea, causing large overhanging plebs, which many of us keep seeing from previous traps. So now the trend is to go for a fornix based, wherein the aqueous can flow posteriorly and in a diffuse manner. All to be taken that the conjunctiva in a trabeculectomy should not be handled with a traumatic forceps. So after the first nick, use a tying good blunt non-traumatic forceps. Any kind of a manipulation of conjunctiva or tenons unnecessarily should be avoided. Do a dissection rather than an intratenons dissection to avoid any excessive manipulation of the tenons. Avoid tears, buttonholes, multiple relaxing cuts unnecessarily. And a dissection just posterior to the limbus, as we would do in case of SICS surgery, should not be done. Rather, here the dissection has to be done in all quadrants. So as you can see in this video, you have to create a deep pocket all around, right? So as to allow a good amount of space for the aqueous to flow posteriorly and diffusely. Tenonectomy, as far as possible, should be avoided even if there is excess whenever you are planning to use an antimetabolite, because otherwise this will lead to a very thin and prone to trauma and rupture kind of blebs. So if you are using metabolite, avoid doing a simultaneous tenonectomy. Then is the hemostasis. Again, here an over-enthusiastic hemostasis should be avoided because it may cause scleral shrinkage and necrosis. While you are doing your cautery, again see that it does not touch the edges of the conjunctiva because it may cause local injury, tissue necrosis and inflammation. Just a good hemostasis to prevent active oozing and bleeding. That much would be sufficient. Then would be the scleral flap dissection. Here, whether it's a triangular or a rectangular, both are fine. Evidence has found that whatever the type of the bleb, it does not interfere with the efficacy of IOP lowering. The only main advantage is a triangular one is easier to dissect and it just requires one mandatory suture. If it's rectangular, then two mandatory sutures at the two ends would be required. The instrument can be either a 15 number Bart Parker blade or a crescent blade. The dissection can be an open flap dissection, as you can see in the video, or it could be just like you make in SICS. You can first make a tunnel through that triangle or the rectangle, and then at the end you can cut the edges to open it up. The care here is to be whatever the shape and instrument you use, a multiplanar dissection should be avoided. It has to be a very single sweeping movement from one side to the other, as you can see, because more the planes you create, more is going to be the resistance to the outflow. So it has to be a smooth bed. Avoid cutting the flap up to the limbus. So the flap should not go right up to the limbus, but just stop a little short of it so that the aqueous can easily flow posteriorly. We don't want it flowing over the limbus and cornea. While you are doing the dissection, sometimes you can see black round holes kind of things. These are the perforating vessels. So whenever you see them, try avoid the slicing through them. Otherwise, they may bleed profusely and it will cause disturbance in your visualization. Coming to the thickness of the flap, it depends on overall the apparent thickness of the sclera and how much flow you want and you are expecting. Because if it is too thick a flap, then the resistance to the flow would be increased. And if it is too thin, then there can be flap dehiscence while handling of flap, or it can lead to increased filtration and hypotony post-operatively. A usual gauged recommendation is about 1/3 to 1/2, but again, it depends, as I said, on a lot of factors depending on how much filtration you want. A mandatory step is now doing a paracentesis. Now, why do we want to do a paracentesis before we make the ostium? This is to allow a gradual release of aqueous and a gradual decompression, because these eyes almost always they are under stages of stresses of high IOP. The optic nerve is under compression. If there is a sudden decompression, then if there was a case of split fixation, it can lead to washout, or sometimes it can lead to expulsive hemorrhages and choroidals. So we don't want all these complications to happen. So always do a good paracentesis. The instrument can be a 26 gauge needle or an MVR blade or even a standard side port blade. A word of caution here is that the direction should be away from the pupil. Like you enter from the clear cornea and it has to be directed towards 6 o'clock. Whereas like in cataract surgery, what we do, we are making a side port. It is usually directed like this towards the pupil area. This should not be done in trab, but it has to be over the iris. Now, why do we want this? Because here the aim is to release the aqueous. So there will be sudden shallowing of the anterior chamber. The lens iris diaphragm will come anteriorly. So especially in phakic eyes where the natural lens is still there, if there is a shallowing, your instrument tip might injure the lens here and it might cause cataractous changes. So it's always a good habit to actually do it parallel to the iris and in an oblique fashion. It has to be a gradual entry and exit. To allow a very slow release of aqueous, right? And of course, it goes without saying that it should be a self-sealing incision. If at the end you feel that this wound is still leaking, do not hesitate to take a suture, right? So that is a gradual release. After this, we do the main step, that is the sclerosome, making the ostium or actually doing the trabeculectomy. So here the limbal anatomy is very, very important. You need to take care that when you have dissected the flap, the blue zone should be well visualized. So if you are doing an open ostium, like without a use of a Kelly sponge, then your first radial mark has to be across that blue-white zone. Second radial mark again here. Then an anterior cut joining the two of them. Then you evert the flap and cut it with Vanas. Okay. If you are doing with a Kelly's Desmet punch, then you just make this anterior cut. And with a Kelly's Desmet punch, you make 2 or 3 punches to make a good ostium. And again, here it's very, very important that these cuts that you make, they should be actually full thickness. It should be kind of a perforating incision, because if you scratch and try to dissect, then the aqueous will start leaking, the eye will become hypotonous, and it might be sometimes very, very difficult to complete the rest of the ostium. And scleral fibers might be left behind, which will cause resistance to the outflow. So always that this window that you make is very, very clean and devoid of any kind of a scleral tissue. If you are doing an open flap cutting like this, then when you evert the flap, you can almost always see this brown pigmented band. That is the trabecular meshwork. Of course, the amount of pigmentation would vary from an individual to individual, but you can almost always see that band that is there. So our cut has to be posterior to that, because if you cut it anteriorly, you might just be cutting up a part of the sclera and you would not actually be excising the trabecular meshwork, what we call as trabeculectomy. So please ensure that your cut is posterior to this meshwork. Otherwise, you might wonder why my trap is fails, mainly because you're not in the right anatomical region. So evert, confirm that this is there. So this is just an animation, two cuts, anterior cut, evert, confirm that you are in the right plane, and then you can excise. The moment you excise, the iris would almost always automatically prolapse through that ostium. So now you do an iridectomy here. So just pinch a iridectomy, keeping two instruments at right angles. Put it on a stretch on one side, cut, put it on a stretch on the other side, and complete the cut. So this will give you a good triangular broad-based iridectomy. And why do we want to do this iridectomy? The main purpose in this surgery is that iris tissue should not be plugging that ostium. Otherwise, iris will be drawn towards that open space. There will be synechia and your ostium will close in no time. So that is why the base should be broader than the ostium and it should be a clean area devoid of any iris tissue. Avoid any kind of forceful pulling of the iris. Otherwise, this may cause dialysis or even lens damage, zonular damage. And after that iridectomy is done, avoid inserting any instruments into the AC through that iris hole for repositioning of the iris, because you are right over the ciliary body, over the zonules. So sometimes you might inadvertently injure the zonules, invite vitreous, and your surgery would fail right there and then. So what you can do is just put a flap back, stroke gently over the limbal area and cornea, and the iris would almost always fall back into its place. And you should be able to visualize a good patent iridectomy from outside. And then comes the closure. So again, here the aim is that the aqueous flow should be directed posteriorly. So one of the sutures, of course, is mandatory at the apex. The others can be interrupted sutures or they can be releasable sutures. They can be one or more releasable sutures depending on your own experience and the risk of failure and success that you are expecting. But they should be more towards the limbus and not in the center, because we want this posterior area as open as possible to the aqueous to flow posteriorly. The knots should be buried, and as I said, they could be releasable, interrupted, adjustable, whatever. So this is just a video of showing how I take a releasable suture. There are different ways, different techniques, with knots, without knots. So just showing schematically, the first step is you remove the corneal fixation suture, because that is the same place where you are going to take the releasable. So we don't want both the sutures to get entangled with each other. So the fixation suture, the first bite that you take is a horizontal bite in the clear corneal area, just like you took the corneal fixation. The second bite would be across the limbus, right? From the cornea coming out to the scleral flap in the center. The third bite would be wherever you want to take your, either this right side, left side, wherever you feel you want to take, you take a bite there. Here you don't pull the suture through and through, but you leave a small loop here, right? Don't pull it through and through. And then when it comes out on this side, you take 4 throws. So 1, 2, 3, 4. And then you bring this loop out through those 4 throws and tie it up. So this is known as a slip knot. So I'll just show in the video. So this is the first horizontal bite. Don't pull it all the way through, leave a little reasonable. The second bite across the limbus. The third bite. Here you don't pull it through and through. You can see there is a loop left. Take 4 throws, 3 and 4. The loop 4 throws. So this makes a slip knot. Now you just pull that external end and see whether this loop is getting released. So you can see the loop is getting smaller. So this ensures that you will be able to release it. And now just trim this one end. The external end, we will trim it only after we have done the conjunctival suturing, because sometimes if it is small and you are not careful during conjunctival suturing, this end might just get pulled inside and you will lose that external end. The knot also should not be very tight, because we will otherwise will not be able to release it post-operatively when we need it, and it should not be too loose that it actually does not serve the purpose of a suture. Now, why do we want this horizontal part to be there? Why not start directly from the vertical end? Because if we just take the vertical side, sometimes with blinking, it rubs like a viper over the superior cornea. It's causing a windshield viper epitheliopathy. So that is why we take this horizontal bite, so the suture lays flat on the cornea all the time. This end should be not too short that you're not able to pick it up and pull it, and not too long that it causes irritation, discomfort, or serves as a easy nidus for infection. And finally, the conjunctival closure. Of course, it has to be watertight no matter what suture you use or what technique. It could be a 10-0, it could be a vicryl suture. If it's a interrupt, just two wing sutures at the end. And if necessary, you can take one anchoring suture at the center, or it can be continuous also. That is again variable depending on your experience and preferred practice. As beginners, always be in the habit of doing a bleb titration. So the AC and the bleb, they have to be formed in proportion to each other. Sometimes the AC might get shallow when you inject fluid through your side port, and the bleb might become very elevated, which shows that there is overfiltration. So you might have to either tighten your scleral flap suture or maybe take one more. Or sometimes the AC becomes very deep, but the bleb still does not form when you titrate. So this suggests that the filtration is not happening, that your ostium is probably not good enough or not clean enough. So you might have to just open up and redo the things. So do a bleb titration to ensure both the AC and bleb are formed. Post-operatively, an important advice to be given to the patient is that all pre-op IOP lowering medications need to be discontinued, because many a times they might be using acetazolamide or glycerol or whatever, or they continue to use the anti-glaucoma drugs because they are using it in the other eye also, and you would just land up in an unwanted hypotony. So please ensure that these medications are discontinued. Of course, an antibiotic, steroid, the drug route and duration would depend on what is the risk of failure, what is the level of inflammation, and of course the cycloplegic to keep the AC formed to prevent malignant glaucoma and keep the lens iris diaphragm posteriorly. Lastly, just two slides about mitomycin, because this is the drug which is very commonly used nowadays, and in fact in most primary cases also we do use MMC. So there could be two ways of use of MMC application. One is the traditional sponge method. Here the concentration and duration are varied. Different surgeons practice different techniques and different durations. It would all depend on what is the risk of failure and what is the health of conjunctiva and sclera. Earlier, the mitomycin sponge used to be placed only on the region of the flap, and but now it is like multiple sponges placed in multiple quadrants. Again, some people use subconjunctivally, some also used below the flap sponge. Again, it's differing practice. But the thing is that while you're putting the sponges, they should not be coming in contact with the conjunctival edges. Otherwise, the healing would be impaired and delayed. It should be covering a larger area to have a more diffuse bleb. And after removal of the sponges, do count the number of sponges that you had placed and wash thoroughly with a copious amount of irrigating fluid. The second method, which many of us have switched over to, is a subtenuous injection, because this gives a more predictable delivery of mitomycin rather than the sponge technique. So this is a small video.
In this video, I shall be demonstrating the technique of subtenuous mitomycin C injection during conventional trabeculectomy. Mitomycin C vial having 2 milligrams of the drug is diluted with 20 ml of sterile water, creating a concentration of 0.01%. Once the corneal fixation suture is taken, 0.1 ml of 0.01% mitomycin C is injected in the subtenuous space at a distance of about 7 to 8 millimeters away from the limbus in the area of the planned bleb using a tuberculin syringe and 26 gauge needle. prevent the drug from egressing out and is placed at the port of entry to prevent the drug from egressing out and over the surface. Then, using two sterile cotton buds, the injected mitomycin C is spread diffusely around the area gently and slowly.
So here, the main important thing is that the diffusion should be good enough. You have to spread the mitomycin that you injected in the posterior area in a diffuse fashion so that the effect stays over a wider area and you have a good posterior diffuse bleb. And now just a change that many of the surgeons, they have switched over to using a 30 gauge needle rather than a 26. So that's again a matter of practice and experience.
In this
So that's all about learning of a trabeculectomy. Thank you so much. Hello.
A minute, doctor. They are there with you.
Yeah. I was just wondering, am I lost?
Excellent presentation, ma'am. It was very nice.
Thank you, Dr. Lakshmi. Dr. Prasanna, Dr. Rolika.
Purvi, I'll take over. I think
Yeah, please.
they're lost somewhere, and we should not be wasting precious minutes. Yes, of course. An excellent presentation of step-by-step trabeculectomy, keeping in mind, the what you should and should not be doing at every step. Very, very good learning. I just wanted to bring out a few points, which of course always come up whenever you're talking about trabs. I practice rectangular flaps routinely, and I feel that the bleb morphology you get with rectangular flaps is something you don't get with triangular flaps. And the way I know is because I have worked with colleagues who do triangular flaps, and I have seen their bleb morphology. It tends to be more anterior, it tends to be less diffuse, and it tends to become cystic, thin-walled quite a bit, because the one feature of a triangular flap is you are actually putting a suture at the apex, which is what would bring about a posterior drainage. So with the uh, rectangular flap, you've got two. So posterior drainage has much greater chance compared to sideways drainage.
Triangular.
What do you have to say about that?
Yeah, as I said, means different surgeons have their own experience in a different set of populations also. So probably we learn all from what we have been experiencing in the past. Yeah.
And one other advantage of putting two sutures like that is you can do controlled suture lysis, laser suture lysis. Now, I do very rarely put releasable sutures simply because I have argon laser, and I use do argon laser suture lysis if it's required. I have seen my rate of suture lysis is about 20%. So actually, I feel that you're probably wasting time in OR by putting releasable sutures. Of course, it is very much desirable if you do not have access to argon laser and cannot do a suture lysis, because everyone does not need it. And as you
Yes.
very rightly said, windshield wiper is a concern, and it's not just a concern with vertical, Purvi. I feel it's also a concern when you're doing it horizontally like that. I would give a small tip here. Instead of starting at the corneal end, why don't you start at the scleral end, go in, make a loop, and come back, and then do this. So then you have a loop on the cornea, not a free end. As a result of which, you can just pull that out, and at no point will that suture cause any kind of epitheliopathy of the cornea. Um, and I'm very glad you pointed out about paracentesis actually, because there are two schools of thought. People say that as soon as you do a paracentesis, you are um, predisposing the eye for cataract formation. The direction is important, as you noted. And I feel titration of the bleb is also important, not just for beginners. Why should you say it is only for beginners? One should titrate the bleb. One should be able to see a good bleb formation at the end of the surgery, and that can only happen if you have a paracentesis. So I do it in 100% of cases. And the construction of the ostium, um, Kelly sponge does not cost a lot of money and is much more controlled. In fact, for beginners, I would suggest Kelly sponge rather than actually constructing by marking out and then cutting through. That does make it a little bit messy. Just one anterior cut and then engage it with Kelly's and just punch. It's way more controlled than manually constructing it. That was my take, but excellent presentation.
Thank you, ma'am. And thank you, Purvi, ma'am, for the excellent presentation as well. This was my thesis topic too, so it's pretty much close to me as well. We have a question, ma'am, from the audience that what adjuvant drugs would you prefer to use and when? Do you prefer mitomycin C or any other adjuvant drug as a spacer? That as per your experience with TRAP.
So, as a spacer, I think the Ologen was the only one which was there, which actually you can label it as a spacer. But now that's out of practice. So we are just left practically with the anti-metabolites, and some work is now being done for anti-VEGFs also. So whether they play any role to modulate the wound healing. But my preferred practice is using a subtenance mitomycin C.
Right, ma'am. And ma'am, how long do you keep it and what concentration do you prefer?
So as I said, it's a subtenance injection. So we don't need to keep it. We just need to inject. Yeah, we just need to inject it. And wherever I use sponges, or when earlier I used to use sponges, it's good idea to keep the concentration maybe fixed and keep changing the duration according to the status of and health of the conjunctiva, the sclera, the risk of failure. Because if you keep varying both the components in all patients, it might sometimes be difficult to figure out like what concentration is really working and what duration is working. And the duration could vary anything from say half a minute to about 3 minutes. And studies have shown that beyond 3 minutes, actually the effect reaches a plateau. So it does not make much sense, using it for 4 minutes, 5 minutes. But again, that experience is very, very variable. So the concentrations vary, and the durations also vary from surgeon to surgeon.
One point I wanted to make here, sorry, Rolika, for butting in. Purvi, you are doing on-table injected mitomycin C?
Yes, yes.
Then you are almost immediately
Because,
opening up your eye. So I hope you're doing doing a good flush.
Yes, yes. So basically, I think I understand what you say, because initially when this strategy was started, it was like you have to do it in the pre-operative period and then leave 30 minutes of time and then take the patient into OT. But now, like, many surgeons are switching over to an on-table this thing, and I've been doing this for about more than a year now and have touch wood, no issues with any of the patients or any of the blebs.
But you are flushing, you are using balance salt to flush it out. No.
This is a subtenance, so there is no way you can flush it out. You just spread it. The thing is that I take a good amount of time milking it and diffusing it all around. So it's not just that you inject and you right away open the conjunctiva. So good amount of time is spent in diffusing and milking. So that
Okay,
gives that waiting
I,
period.
I do it in the pre-op area, and
Yeah.
it need not be 30 minutes, you know. Most of the time I do it in the pre-op area and the patient is shifted. So that's the maximum of 10 minutes. It is said that it actually becomes intravascular and it, gets bound to tissue pretty soon, but never tried it on table. On table, when I open, I do put another sponge under the scleral flap for 1 minute, because I found that my rate of suture lysis was increasing. So I wanted to reduce that.
Mhm.
So, as long as you know, observe what you're doing and what changes
Exactly.
need to be made, that's very important.
Yeah.
And
The
ma'am,
catch here is just really like for the viewers, the catch here in glaucoma, unfortunately, is for everything. There are lots of schools of thoughts, lots
Yeah,
of
exactly.
different practices. So the main thing you have to take care of as a surgeon is observe your techniques, your what drugs you are
and what
using, how
suits
you
you.
are doing, and observe it over time, and then
Right.
decide what works best.
Be
Right.
safe. That's the point.
And just to add over here,
a
like
quick
I
question
don't know
here.
if times have changed over the last 7 years, but we used to, like my thesis was to use cross-linked sodium hyaluronate. It was a product called Haloflow. So we used that as a spacer and it worked very well. So that's just one additive point.
Yeah,
And
yeah, it worked well, but for how long, Rolika? That's the question. You know,
mm,
everything has to be measured in terms of time. You know, what is
right,
working
ma'am.
the most versus time. And Ologen also, was a relatively good spacer and good thing in the early post-operative period. But towards the, later post-operative period, it wasn't giving that good result. And that is why, perhaps it is gone out of favor now. I think people are not even making it anymore.
Maybe
Sure.
Rolika, what you said, like use of that high viscosity agent, maybe it was working as that viscocanal kind of a component, dilating the Schlemm's
Yes.
canal for some period
So
of time.
right.
So
It
that might
prevents
be,
it
yeah.
prevents fibrosis in the initial phase, and then what we observed was that it was not causing any blockage going further. So, anyways, that was the study, and I think even now we can always check the long-term follow-up and of how it's going. But that was over 3 years. But thank you everyone for this lovely discussion, and we will go to our next talk by Dr. Monica Arora, ma'am, about MIGS. And I know that we have Doyens over here related to mix, so that will be a great discussion. Yes, ma'am, it's visible.
Shall I start?
Yeah, yes, ma'am.
Good morning, everyone. Thank you, AIS, for this opportunity to me. So my topic is minimal invasive glaucoma surgery. Does not okay. MIGS is a group of IOP lowering procedure with the following characteristics that distinguish it from traditional glaucoma surgeries. It is minimally traumatic. It is minimally traumatic. It has a high safety profile. It provides rapid recovery. It can be combined frequently with cataract extraction. It provides a meaningful IOP lowering, often inferior to trabeculectomy, but with benefit of a safer risk profile. Therefore, these procedures are currently targeted at patients with mild to moderate glaucoma. So why there is a need of MIGS? As we all know, traditional glaucoma surgeries provide a full thickness drainage fistula for the drainage of aqueous, and these are the ab externo procedure, although effective. Complications that are potentially vision threatening like hypotony, wound leaks, infection, inflammation, and post-operative scarring with loss of effect over time have been seen. Therefore, MIGS offer a new idea of microincisions and implants that promise to avoid pitfalls of traditional surgery. MIGS helps in improving or modifying the existing natural outflow pathways rather than bypassing them altogether. So what are the MIGS approaches? The first approach involves enhancing outflow across the trabecular meshwork and through Schlemm's canal. As we all know, resistance, there is a maximum resistance at the juxtacanicular trabecular meshwork, and so we have to overcome this resistance by bypassing or removing this tissue to lower IOP through increased outflow. Therefore, this can be achieved by bypass stent, which allows aqueous to flow directly through the stent from the anterior chamber into the Schlemm's canal, or by surgical incision or excision of this tissue, or by the dilatation of Schlemm's canal through cannulation and expansion with viscoelastic. A second MIGS approach seeks to increase outflow via alternate pathways, that is through suprachoroidal space with microstents placement and conjunctival space. A third MIGS approach involves decreasing aqueous production by ablation of ciliary body. So what are the MIG devices we have? Trabecular meshwork bypass stent placement, iStent first generation, iStent inject second generation, Hydrus microstent, trabecular meshwork bypass by tissue excision by Kahook dual blade, trabectome, GAT, TRAB 360 or Omni, excimer laser trabeculotomy, enhancing aqueous outflow through Schlemm's canal, Visco 360 or Omni, EPIC, enhancing aqueous outflow through suprachoroidal space, CyPass microstent, Solex gold shunt, shunting aqueous outflow into the subconjunctival space, Zen glaucoma implant or preserve flow microshunt, that is also known as InFocus, reducing aqueous production by ciliary body ablation by continuous wave cyclophotocoagulation, ECP, micropulse cyclophotocoagulation. So what are the preoperative evaluation we have to consider? We have to see the stage of disease, the target IOP, tolerance to medication, preoperative IOP control, and the status of the angle. So now coming to the devices, the trabecular meshwork bypass by stent placement, the iStent first generation. The iStent trabecular micro bypass stent received FDA approval in 2012 as the first MIGS implant. This device is a heparin coated non-ferromagnetic titanium stent. The device measures around 0.3 millimeter in height and 1 millimeter in length. There is a snorkel. This is a snorkel with a lumen of 120 millimeter with a height of 0.3 millimeter. And this is a closed body behind this, and this is a half open pipe. This closed body, which is implanted into the Schlemm's canal, contains 3 retention arcs to ensure that the device will remain in place. The iStent is preloaded into a single-use sterile injector. It is implanted with the use of disposable inserter via gonioscopy guided approach from a paracentesis site. The studies conducted on iStent have shown a greater reduction of IOP around 20% with iStent combined with cataract extraction versus cataract surgery alone in patients of open angle glaucoma. Now coming to iStent inject second generation, the iStent inject received FDA approval in 2018. The iStent inject is composed of heparin coated non-ferromagnetic titanium. Each stent is 360 microns in height by 230 microns in diameter. So it has a central lumen of 80 micron meter in diameter with a head which resides in the Schlemm's canal, which have 4 outlets of 50 micron diameter each, and a thorax which resides in the trabecular meshwork, and a flange which resides in the anterior chamber. The iStent injects consist of a single-use injector that comes preloaded with 2 devices which are to be placed 2 to 3 clock hours at the time of cataract surgery. So these are 2 iStent which are 2 to 3 clock hours away from each other. This is iStent inject and this is iStent inject W. The size of iStent inject and iStent inject W are the same. Only the difference is the flange size. The flange in the iStent inject W is around 360 micron in diameter, and the benefit of this is that it provides a better visualization and during implantation, better seating in trabecular meshwork, and reduced risk of malposition and migration. This is iStent Infinite, which has 3 iStent preloaded in 1 injector, and it can be used as a standalone, better access along with multiple clock hours of Schlemm's canal, and it provides a greater cumulative outflow. So what are the common complications? Mild hyphema from the Schlemm's canal, transient IOP spike, corneal edema, stent malposition, lumen obstruction by blood clot or iris, inability to implant the stent, vitreous incarceration, and there can be a need for the second surgery. Hydrus microstent. Hydrus microstent received FDA approval in August 2018. The microstent is 8 millimeter in length, 290 micron in diameter with the 3 windows and an inlet that sits in the interior chamber. It is made up of nitinol, which is flexible biocompatible titanium, and a nickel alloy. The device spans around 90 degrees of the trabecular meshwork. It functions to lower IOP through two mechanisms, that is one from trabecular meshwork bypass and the scaffold of Schlemm's canal to maintain the patency. Studies have shown that hydrus combined with cataract surgery versus cataract surgery alone achieve 20% of IOP reduction. The complication, subconjunctival hemorrhage, hyphema, and formation of peripheral anterior synechiae. There is a horizon trial for the hydrus implant in which hydrus along with the cataract surgery, they have seen that there was an overall IOP reduction and around 7.6 versus 5.3 millimeter of mercury, and the number of medication were also reduced. There in 0 eyes in the hydrus group versus 4 eyes in the cataract surgery group required trabeculectomy, and endothelial cell count was also lower immediately after surgery in the hydrus implant. Now coming to the trabecular meshwork bypass by tissue excision, Cahook dual blade goniotomy. The Cahook dual blade is a specialized goniotomy blade that was introduced in US in 2015. It is designed for improved excision for the trabecular meshwork during goniotomy. The blade is a single-use disposable blade with a sharp tip which is used to pierce the trabecular meshwork. The surgical technique involves an ab interno approach through clear corneal incision with the help of direct gonioscopy. The blade is used to pierce the trabecular meshwork and advanced along the canal to excise the tissue. The Tanito micro hook. The Tanito micro hook features a 3-hook design. One is straight, and the other is a 2 curved hook that is used for right and left. The straight hook can make an incision of about 120 degree, and the curve hook can also achieve another 120 degree, allowing a total excision of 120 to 240 degree. The flexibility is the most significant advantage with the Tanito hook. Now coming to trabectome. Trabectome is a surgical system developed by Neomedics. The system works by removing a strip of trabecular meshwork with the help of microcautery ablation system and the inner wall of the Schlemm's canal in order to create a path for the drainage of the aqueous humor. It is a single-use disposable handpiece that performs electrocautery, irrigation, and aspiration. The studies have reported significant IOP reduction with trabectome, similar to trabeculectomy. Higher the baseline IOP, the greater is the IOP reduction. The complication are intraoperative blood reflux is seen in almost 100% of cases, goniosynechiae formation, and membrane growth. Now coming to GAT. GAT is an ab interno trabeculectomy. Under direct visualization with a gonioscopic lens, goniotomy is made in the nasal trabecular meshwork, which serve as the entry point for the eye tract microcatheter. We can also use a 4-0 proline suture instead of the microcatheter. Microsurgical forceps are used to advance the microcatheter or suture into the Schlemm's canal circumferentially 360 degree. Once it has been passed through the entire canal, the distal end of the catheter is grasped and the proximal end is retracted out of the eye, sharing the trabecular meshwork to create a 360 degree trabeculotomy. Trap 360. The Trap 360 is a single hand use piece that allows the surgeon to perform trabeculotomy through a clear corneal incision. The tip of the handpiece is used to pierce the trabecular meshwork, and the microcatheter is advanced from the tip of the device and threaded through 180 degree of Schlemm's canal. With the microcatheter still in the Schlemm's canal, the device is retracted from the eye, carrying the microcatheter through the trabecular meshwork for 180 degree. The device is then rotated and reinserted, and the procedure is repeated for the remaining 180 degree of the angle to accomplish a full 360 degree treatment. Excimer laser trabeculotomy. It uses a wavelength of 308 nanometer, which is attached to a quartz fiber optic probe. The procedure intends to enhance outflow facility by creating micro perforations in the trabecular meshwork and inner wall of the Schlemm's canal. The probe is beveled at 65 degree to aid the placement against the angle via gonioscopy or endoscopy guidance. And 8 to 10 laser punches are spaced over 90 degree and each having a each having an energy of 1.2 millijoule over 90 seconds. The whitening of the trabecular meshwork by blood reflex from the laser site is the end point of the excimer laser. And now coming to the enhancing aqueous outflow through the Schlemm's canal. Visco 360 device allows for catheterization and viscodilatation of the Schlemm's canal. It is similar to the TRAP 360-degree device. It is a single-use, single-handed device with a sharp distal tip that is used to pierce the trabecular meshwork, and microcatheter is then advanced through 180 degree of Schlemm's canal. The procedure is then repeated for the remaining 180 degree of Schlemm's canal. The procedure allows dilatation without tissue destruction of the natural drainage system. This is Omni surgical system. This is Omni. The Omni is a single-handed, single-use device that performs canaloplasty and trabeculotomy. This addresses the outflow resistance from the trabecular meshwork, that is trabeculotomy, and distal by dilating the Schlemm's canal and collector channels, that is canaloplasty. The Schlemm canal is assessed at the nasal angle and a microcatheter is advanced circumferentially with a thumb wheel. On retraction, viscoelastic is dispensed, advancing the microcatheter a second time and removing it without retraction performs a trabeculotomy. Now coming to ab interno canaloplasty, TABIC is performed using the I-track microcatheter system, which is 250 micron microcatheter with a fiber optic allowing for visualization of the catheter while in the Schlemm's canal. After making a nasal goniotomy, the catheter is advanced 360 degree into the Schlemm's canal and slowly withdraws while performing viscodilatation, the canal, and the distal outflow system. This approach allows for enhancement of the natural outflow system without tissue destruction. Now, enhancing aqueous outflow through the suprachoroidal space. So, CyPass microstent is a polyimide supraciliary device for ab interno implantation. The goal of this device is to create a controlled cyclodialysis cleft. The stent is 6.35 millimeter long with an outer diameter of 430 microns and an inner diameter of 300 with 64 fenestration along the length of the device. During the surgery, the implant is loaded onto the retractable guide wire, and because of the flexibility of the stent, it is able to assume the curvature of the guide wire, allowing the stent to conform the scleral curvature. The device is inserted to the initial phacoemulsification incision and advanced to the scleral spur. After that, the guide wire is used to perform blunt dissection of the ciliary body in order to allow the passage into the supraciliary space where the stent can be placed. The proximal end of the stent has 3 retention rings. These are the retention rings to allow improved stability of the device in the angle. So these are the 3 studies, but the important is the COMPASS study, which the COMPASS extension trial, in which they have seen that there was a significant endothelial cell reduction. Therefore, this led to the voluntary recall of the device in August 2018. The iStent Supra. The iStent Supra is a rigid tube of heparin-coated polyether sulfone approximately 165 micron in diameter with a curve designed to follow the supraciliary contour. The iStent Supra is positioned ab internally through the trabecular meshwork into the suprachoroidal space. It is a preloaded on a single-use inserter, which is advanced through a small temporal corneal incision. The mini inject, is an oblong implant made up of micropore silicone. It has a 27 micron spherical pores, and 2/3 of the implant is empty space. When positioned in the eye, 0.5 millimeter remains in the AC. BioStent, it is a highly permeable acellular scleral allograft. It is delivered by a cyclodialysis microcannula and expands by 10% on insertion. This is a Solix gold micro shunt. It is made up of 24 karat gold, medical grade, biocompatible material to minimize tissue ingrowth or protein adherence that causes blockage. It is 3.2 millimeter wide with a 5.5 millimeter long, and the thickness is 44 micron meter with a weight of 6.2 milligram. The shunt is composed of two rectangular fused leaflet with a rounded proximal end and a distal end ends with fins to anchor the device in the suprachoroidal space. A series of microtubular channels that connects the anterior chamber with the suprachoroidal space. The device is positioned through a fornix-based conjunctival flap and a 4 millimeter full thickness scleral dissection into the created suprachoroidal space by ab externo route. Now coming to the shunting aqueous outflow into the subconjunctival space. This is also known as MIBS, minimal invasive bleb surgeries. The first in this is a Zen glaucoma implant. The Zen glaucoma implant shunt aqueous from the anterior chamber to the subconjunctival space. This implant is currently the FDA approved device which utilizes this approach. The Zen implant is a 6 millimeter device composed of porcine derived gelatin cross-linked with glutaraldehyde. The inner tube has a diameter of 45 micron, whereas the outer having 150 micron. Based on the inner lumen diameter, there are three versions: 140, 63, and 45. After implantation, the gelatin in the stent hydrates slightly, causing expansion of the device to ensure improved stability. The gel stent is loaded in a single-use, single-handed disposable injector with a 27 gauge needle. The injector is inserted into the anterior chamber through a clear corneal incision, and the tip of the injector is used to pierce through trabecular meshwork and the sclera into the subconjunctival space. Mitomycin C is typically injected subconjunctival before or after the stent placement to limit bleb fibrosis. Now coming to preserve flow microshunt, formerly known as in-focus microshunt. The shunt is made up of SIPS, polystyrene, isobutylene styrene. It is a biocompatible material. The preserve flow device has an overall length of 8.5 millimeter and a beveled tip. There are 1 millimeter fins are there to allow fixation and prevents peritubular leakage. The device is inserted using the ab externo approach through a small scleral pocket, and the scleral pockets are made to fix the fins in this so that it allows fixation and prevents peritubular leakage, and scleral pocket into the anterior chamber. Now coming to the reducing aqueous production by ciliary body ablation. Continuous wave transscleral cyclophotocoagulation. It works on the mechanism of coagulative necrosis by applying diode laser energy to the ciliary process, which is absorbed by melanin containing cells. The conventional laser utilizes the parameter of 2.0 watt for 2 seconds. And now parameters are changed, and that is known as slow coagulation protocol, in which the power is lower down to 1250 milliwatt with a longer duration of 4 seconds. So this is the studies have shown that this provides efficacy comparable to conventional, but with fewer complication, faster recovery, and better cost utility. Continuous wave, we spare 3 and 9 position, 3 and 9 clock hour, and we give in each quadrant around 4 to 5 shots, and a total around 16 to 20 shots are given 360 degree, sparing 3 and 9 o'clock. Micropulse transscleral laser therapy. It works on treats the ciliary body with minimal coagulative necrosis. It has a short repetitive laser pulses separated by rest periods and is purported to work through a direct effect on the pigmented ciliary epithelium and increase trabecular meshwork and uveoscleral outflow. It has a 31.3% of duty cycle, and each pulse is on for 0.5 millisecond and off for 1.1 milliseconds. The parameters are 2000 milliwatt for 160 second, 80 second per hemisphere, and 4 sweeps at 20 seconds per sweep. So we have to give one sweep like this for 20 seconds, another for 20 seconds, and again in the inferior hemisphere, we have to give 20 seconds one sweep and another for 20 seconds. Now coming to ECP, Endoscopic cyclophotocoagulation involves using a probe inserted by a clear corneal incision near the limbus that enables laser application to the ciliary process under direct visualization. This limits tissue injury to the ciliary process and its capillary bed while sparing the ciliary muscles and stroma. Several studies have demonstrated the efficacy of phacoemulsification. One study reported 55.5% success rate with a mean IOP reduction from 21.1 millimeter of mercury on 2.7 medication to 16.1 millimeter of mercury on 1.5 medication at 1 year follow-up. Thank you.
Thank you. Thank you, Dr. Monica, for covering extensively on MIGS. We do have some of the pioneers of MIGS. Vanita ma'am is one person who I personally looked up to when we started our journey, and most of the young ophthalmologists, we all looked up to madam. Ma'am, your take on the MIGS in India as of today?
Thanks. Thanks a lot. But I just wanted to point out a few things. Monica has been very extensive in her coverage, but there are many, many that are actually being withdrawn from the market. And so, I don't think you should be confusing future generation ophthalmologists with all this. Of most note is the trabecular micro bypass. We don't have generation 1 or generation 2 anymore. The only one that is available worldwide is iStent Inject W and iStent Inject Infinite.
Infinite.
Yeah. Infinite is not available in India yet.
India. Yes.
Then suprachoroidal, every single suprachoroidal that you have talked about have been withdrawn, except for the Miniject. Miniject has not got FDA approval yet. It has got the CE mark, which is the European equivalent, but definitely not the FDA. Then Solex microshunt is a very invasive surgery. I don't know how you put it in MIGS. It requires a lot of dissection, and in fact, Solex has been withdrawn. It's no longer used, this gold device. And one complication which I found very interesting, you talked about in trabecular meshwork. The iStent is vitreous incarceration. How? You're in the anterior chamber, unless you have had a complication. Okay, complication of what? In your cataract surgery, vitreous will not come to the AC at all. So how you talked about vitreous incarceration, I didn't understand. You did not give any references there. Anyway, coming to MIGS in India, I see a bright future. Slow but steady. Irrespective of the fact that there are many, 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 many naysayers still. But from where we started, now, mind you, the Kahug dual blade had FDA approval 2015, and I actually got a few blades from the US, and I have tried it in India as long back as 2015. I have been doing ECP for I don't know how many years, and so these are MIGS also. MIGS, unfortunately, in our country is translated to the two devices that are the most expensive, and they have their own place in the management of early glaucoma. So what is very important is that whereas previously we did not have any option in early glaucoma, it's not that patients did not go out of control in early glaucoma also. You don't want to put a patient on 5 drugs in early glaucoma. I don't want to. Okay, even in advanced glaucoma, I don't want to. The only reason why my patients would be on 5 drugs, even in advanced glaucoma, is because they don't want surgery. That's a different matter. But when in a glaucoma patient, if you are undergoing cataract surgery, then I think providing the option of MIGS, any MIGS, that you or is being followed in your hospital or institution is, I think, mandatory now. Patients will not dream of this option. They have to be given this option. You can't say, I'll do a cataract surgery, you carry on with your drops. No, I will give the option in early glaucoma to simply because glaucoma is a lifelong disease. So even if I can take them off their medication for 3, 4, 5 years, which may be an overestimate, I don't know, but I have done so. I mean, I have data showing me that patients have been off drops for that long. Then what you're doing is, if you are restarting them on medication, then you are readjusting, or their what I call the anti-glaucoma medication clock. Otherwise, what happens is, if you don't catch them early and treat them and reduce their medication burden, or even eliminate it altogether, that is something also you did not point out at all in any of your slides, that one of the greatest advantage of doing MIGS is you can reduce anti-glaucoma medication by at least 80%. That is the type of outcomes I am getting in across the board, across most of the MIGS that I do. So I'm very encouraged. I feel that if I can stop it now, and if we can readjust the AGM clock for a patient, then perhaps in their lifestyle we can stop a trab. Because at the end of the day, trab is essential in advanced glaucoma. There's absolutely no doubt. But is it what you would like to do? I know of so many patients who come to me who say that I have been under a doctor, and a glaucoma specialist or not, I'm not commenting on. They have watched me, and now that my glaucoma, I'm feeling my vision is worse, they are saying that doing surgery is not safe, that they will lose vision, that they will be a wipeout. That's because the only option then is a trab. So I think there has to be a shift in our mentality. We should be not only trying to catch them early, but also treat them early first, and then over their lifetime, hopefully avoid any invasive surgery. But you still have to learn your invasive surgery, and trab will continue to have a place. There is no doubt. Right now, in my practice, trabs are happening mostly in phakic eyes who don't have cataract. But mind you, even then, there is very good data out there which says that by the end of 1 year, 30-35% develop cataract, no matter how careful you are in doing your trabs. So, unfortunately, that is the sad reality. But if we only want to live for the day, then, we lose the woods for the trees. That's what happens.
Thank you. Thank you. Thank you, ma'am. Purvi, ma'am, your comments, ma'am, before we move to the next talk.
Unfortunately, I cannot provide extensive comments on mix because I personally do not have much experience, mainly because of the cost limitations that the patients we have in a government setup have. I have been trying the bent angle needle gonectomy, so that is working fair enough, because again, our patients, they cannot afford the KDB or the other options. So, but again, very limited experience regarding that. But yes, that is an option which definitely needs to be considered in all those patients where, as Dr. Vanita said, either we are offering a cataract surgery or mild to moderate cases, and it is definitely an interim measure you can consider before you straight away move to doing the more invasive trab. But again, having said that, since this is a more PG focused webinar, the message needs to be go across that trabeculectomy is still the gold standard, and one should not, just get carried away by the lot of marketing that is there about any type of a surgery or procedure. And you just need to use it judiciously for your patient, considering their individual profile, their ocular profile, their overall systemic profile, and then decide what is best for them. So whether it is medications, it is MIGS, it's a device, or it is a trap. So the
That is,
PGs
that
just
is
need to keep this in mind.
that is exactly what I'm trying to say. Judicious use of
Yeah.
trap as well. Because traps, if not performed well, unfortunately fail and fail very quickly. And if you don't nurse them like a baby in the first 6 weeks, you're just putting them back on medication again. And that is happening quite often. These are the type of patients I see, unfortunately, in my practice quite a bit, who have had one trap, two traps, and considering a third trap as well. But that's
And
where
again,
we
yeah.
need to draw a line. We need to, we need to say, if one trap has not worked, please, at the end of the day, you are creating a hole in the eye. Like it or not, it is a hole in the eye. And if the conjunctiva becomes thin walled, cystic, then you are predisposing that eye to a lifelong risk of leaks and infection. Blebitis, bleb-associated endophthalmitis, these are sight-threatening complications. These are not minor complications.
Thank you,
And
ma'am.
Dr. Prasanna, just one
Yes, ma'am.
tip, yeah,
Mhm.
that trying to perform MIGS, it is very, very important to master the art of intraoperative gonioscopy.
Yeah.
Because that is again it's a skill which needs to be mastered, so that just doing a diagnostic intraoperative gonioscopy first, once you master that skill, then as a second step you can go on to performing the actual surgeries.
Yes, ma'am. To add on to that, I was just about to say the same. So most of the Indian residents or fellows have the tendency to do gonioscopy in their right hand. So what I tell my residents and fellows is try to do gonioscopy in your left hand in the OPD itself. Start with a Goldman lens, which has a visco-coupling fluid, HPMC or OVDs. And then go do it with a Zeiss lens, a Posner or a Sussman, and without any fold on the cornea with your left hand, and then that will help you to garner good attention, and you'll be able to be very mindful when you go to the OR and you do predominantly with your left hand. So trying to develop your left hand skills would really mean a lot of difference going forward. And for recent advances, I think as the doyens is covered, Vanita ma'am and Purvi ma'am, this will be a very important recent advances for the postgraduate and residents who are listening to all of us. There are diverse options of MIGS, ranging from excisional procedures to ECPs, and now the recent one we had was the IDRES launch in India. So thank you, ma'am, and thank you, Dr. Monica, for a wonderful and extensive coverage. With that, ma'ams, we'll move to the next lot, the third speaker. We have glaucoma drainage devices by Dr. Teki Todam Tara. Dr. Teki, are you with us? Yeah. So we'll move to your talk, Dr. Teki. We'll go for from minimal invasive, I think, to macro invasive, maybe. Yeah, the glaucoma drainage devices. We can see your slides.
Okay.
Yeah.
So my slides are visible?
Yeah, visible and moving. Please proceed.
Okay, sir. So good morning, everyone, and thank you, AIS, for this opportunity to present. I'll be talking on glaucoma drainage devices. Glaucoma is a disturbance of structural and functional integrity of optic nerve head, which is arrested by adequate lowering of intraocular pressure, and which is the only modifiable risk factor. And there are various modalities to treat glaucoma. First, to start with the medical management, then we come to the surgical management, and then yes, we have other options for management is laser. So coming to the drainage devices in glaucoma, first is Seton. Seton refers to a non-hollow linear sub that prevents wound apposition. Then shunt is a passive tubular structure incapable of influencing either antegrade or retrograde flow. And bulbs are tubular structures for unidirectional flow. when they perform the paracentesis using horsehair through the corneal puncture to treat patients with painful absolute coma. So let's come to the history. In 1969, the concept of tube and plate GDD and made of polypropylene was introduced in 1979. And in 1990, barbell GDD of silicon material was introduced. And in 1990, again, propene with disc GDD of silicon oil. And in 1993, Ahmad GDD of polypropylene with silicon bulb that is having pressure sensitive and unidirectional bulb was introduced. And in 2023, ADI, an Indian product, was also introduced. So the implants can be studied under types of plate, that is can be rigid and flexible plates are available. The advantage of flexible plates are that it causes less inflammations, and based on types of materials also, the most common materials now used are silicone then polypropylene. And based on types of the opening, that is GDD with no resistance and with variable resistance. So the question is whether the plate material influences the IOP. Yes, may affect the tissue reactions and degree of bleb encapsulations. Ayla et al. Had done a study where they demonstrated more inflammation with polypropylene plate when they compared with the silicon plate and when they inserted subconjunctivally in the rabbits. And then also like two prospective study compared with AGB silicon and polypropylene reported the same results. Then, in one prospective multi-center comparative series, AGB silicon versus polypropylene was done, which showed good IOP control with the silicon, but more tendencies with the polypropylene group. So again, does the plate size affect the IOP intraocular pressure? Yes. So Hoare et al. Has done a study in which they found that Molteno with double plate had a good control IOP as compared to the single plate. And also double plate Molteno had a better IOP control than the single plate AGB. And barbell implant of 300 pp and 500 were also compared, but here 300 pp showed better IOP control. And it was seen that 500 group had more complications of hypotony, and at a certain size, that is about 200 to 250 to 350, the size effect of the plate size on IOP becomes almost comparable, and after 350 size, it tend to plate you down. So the plate size mainly affects the long-term IOP, not the early post-operative IOP. So let's talk about the GDD with no resistance, that is non-bulk or no non-restricting implants that relies on resistance formed by the fibrous capsules or the bleb. Examples are ADI, Molteno, Barbell, Socket, and others. So Molteno implant, which is the original design, the first recognized successful GDD used in the clinical practice. It comes in double plate also. With the double plate, the advantage was had a better IOP control, but had higher complications like hypotony. And they had developed another one like dual chamber, that is single plate implant, which had a pressure ridge in the upper surface to minimize the excessive filtration and then hypotony. So Molteno 3, this had bowl-shaped structures on the plate immediately at the opening, designed to function as a biologic bulb by limiting the available area of filtration during the times of low aqueous productions. So barbell implant, which is I think one of the most common non-bulb GDD used globally. So this is a silicon tube attached to the silicon plate, which is barium impregnated, comes in a various form. The advantage is it has a penetration that allows the growth of tissue through the plate, serves to reduce the height of the blade, which reduces the risk of diplopia and helps secure implant. So socket tube shunt, there is anterior chamber tube shunt to encircle the band. Okay, this is a silicon or silastic tube extending from the anterior chamber to a 360-degree encircling silicon band, and is used in retinal, used in the retinal detachment to repair, which functions in developing the reservoir for aqueous drainage, but no longer used in routine clinical practice. So let's talk about the bulb or flow restricted implants. So basically only drains fluid at a certain intraocular pressure level. So here what happens is the bulbs opens and fluid is drained to the reservoir where it is absorbed by the surrounding tissues. For example, most commonly used is the AJB, then Cropin slit and others. So GDD with variable resistance are like Molteno dual ridge devices, gold microsons and others. So why and when do we need GDDs? It is most of the time used in a refractory glaucoma, especially in our country. So why in a refractory glaucoma? Because in refractory glaucoma, the inflammations are more. In NVG and ICE syndromes, they develop membranes which glows over the angle, leading to the closure with the trabecular meshwork. Ostium might get closed, and also scarred conjunctiva because of the previous surgeries. So other indications are pediatric glaucomas, aniridias, Sturge-Weber syndromes, and many others. So there are a few contraindications, like especially in eyes with severe scleral thinning or sclerolimbar thinning, or extensive fibrosis of the conjunctiva where GDD implantation is not possible, or ciliary glaucoma. So how does it work? Basically, fibrous capsules forms around the plate in 3 to 6 weeks, which acts as a reservoir and aqueous pulls in potential space between the plate and the capsules. Then the passive diffusion of the aqueous out of the eye and it is absorbed by the capillaries and the lymphatics. So GDD forms a plate around the flat that is away from the limbus, and in 5 to 6 weeks, the suture lysis happens and the plate ridge gets obscured, and the vicral suture which is used to ligate it's not visible by that time. So what are the pre-operative considerations before going for any GDD implantation? First is seeing the ocular adnexia like lead, then conjunctiva. We have to see the conjunctival health, the scarring, the mortality, the mobility, and the thickness and thinness of the conjunctiva. Then yes, the sclera, is there any scar or any wound or thinning? And then cornea. One of the important things is we have to look into the corneal health, and we have to check the specular like endothelial cell counts, because early and as well as late complications are corneal decompensations in the late phase, and sometimes because of the tube touch. This is one of the common complications that we face, and we have to see the anterior chamber depth to plan for implanting the tube. And then quadrant of the surgery has to be seen and then decided before the surgery. And yes, based on the case, we have to plan whether the tube has to be placed in the anterior chamber, sulcus, or in the vitreous cavity. And yes, we have to look into the systemic profile of the patient. Then yes, anesthesia, whether to go under local anesthesia or under general anesthesia. And yes, giving intraocular pressure, IOP lowering medications before or surgery as per surgeon's discretions. Now, the tube placement in the anterior chamber is done, especially in case of phakic eyes with clear lenses. Then ciliary sulcus lenses are placed, are favorable or are done in patients, all the patients where the endothelium are found to be compromised or pseudophakic or aphakic eyes. And in vitreous cavity where PPB is required, or aniridia or any other retinal conditions associated with glaucoma. So the placement of the tube first is the most preferable site is the superotemporal quadrant, then is the inferonasal quadrant, then superonasal quadrant, and then superonasal quadrant. So though rare, but some brown when the plate is placed in the superonasal quadrant, it is sometimes associated with brown superior oblique tendon syndrome. So placement of the tube. So it can be placed under partial thickness scleral flap. It can be placed under scleral or corneal patch graft, and it can be placed under long scleral tunnel without any patch graft. This is all based on the surgeon's choice and their modification and their expertise. So this is just a video. I'm just showing how the partial thickness scleral flap is being created and the tube is being placed inside it without putting a patch graft. So this is again where we're using a corneal patch graft to place it over the tube. Now this is a scleral long patchless tunnel track where actually we do this thing, create a long subscleral tunnel for about 4 mm, and this actually created slightly 2 mm away from the primary position to create a kinking, to just so that the tube directly doesn't go inside, but with a little bit of bending. And advantage they have noted is one thing is that micro movements or maybe retractions are reduced probably. And another thing is maybe if the tube is retracted, we can put it in another this thing. Or if the tube is short, we can put it through another hole. So this is RD is a non-bulb glaucoma drainage device, which is almost similar to barbell. And I'll be talking a little bit about this implant is because this is most commonly practiced in our country. Previously, there was only 350 size. Now 250 size is also available. So the key features is it has a large surface area and it can be implanted in a single quadrant insertion, and its flexibility of the material. The unique feature is it has also penetrations that allows the growth of the fibrous tissue to control the bleb height and volumes and to secure the plate in place and minimize ocular motility disturbances. So this is the surgical steps. Most of the surgical steps, the basic are almost the same in all the GDD implant. With certain modifications based on the materials they use and based on the implant they use. So initial is the corneal traction sutures that can be done with different suture as per surgeon's choice. Then conjunctivotomy about 3 to 4 clock hours or about 100 to 100 degree this thing. Then muscle isolations in case of large plate is being used. If it is not large plate, then muscle isolations are not needed. Then we have to check the tube patency and the plate has to be washed before these materials are being used. And then yes, fixing the plate of this thing are placed at around 8 to 10 mm behind the limbus by nylon sutures. And then yes, in case of non-bulb implant, tube ligation is very important that we do with the vicryl sutures. Some put one ligating sutures and many others put 2 ligating sutures. And this has to be confirmed before closing it. So after the tube is being placed in the anterior chamber, we should do a close watertight conjunctival closure. Again, the suture being used is based on the surgeon's choice. So the problem with the non-bulb GDTs are the post-operative hypotonies. So there are various modifications that has been done to prevent the hypotony in case of non-bulb implants. These are like external and tube, like external tube occlusions, that is ligature. Most of the time this used with 6O or 7O vicryl sutures, and then internal tube occlusions with 4O or 5O or nylon Prolene sutures in the tube lumen, and yes, venting or Serho's cleats, and then some people do 2 staging procedures. So hypertensive pace, these are found to be in case of non-bulb implants also, though the percentage of present are less as compared to the bulb implants. And I'll just discuss about the Ahmad glaucoma bulb, which is the most common bulb implant that we use. So it is a bulb GDD with silicon tube connected to a silicon held in end plate polypropylene or silicon, and it consists of a thin silicon elastomer membrane to reduce internal frictions with the bulb system. So it has a venturi effect is generated to help the aqueous flow in a unidirectional flow. So it has a various parts, that is the elastomer foils that regulates the one-way flow, and the tapered chambers that creates a venturi flow towards the bulb body, and there are fixating eyelets and then assemble bolts. So there are different models available, and most common models that we use either PF7 and PF8 for pediatric and small globes. The advantage of a bulb, this thing, GDDs, are that there is immediate reductions of intraocular pressure, unique pressure sensitivity bulb to prevent the excessive drainage and chamber collapse, then single stage implantations, and it also eliminates the need of tube ligature, suture, ripcord, and occlusions. So the mechanism is that aqueous is transported to the body's bulb, where it has to pass between the two silicon elastomer foils held in place by polypropylene fees at a certain tension. The initial pressures needed to break the adherence of this membrane often exceeds more than 100, but afterward the separate whenever the pressure is only when it is about more than equal to 12 mm of Hg, and closes when the pressure is less than or equal to 8. So this mechanism permits one-way flow. So priming is one thing that we have to know, that is done with the AGB. That is basically when the 27 gauge cannula is inserted to 2 to 3 mm into the tube, and BSS is injected to separate the elastomer foil. Often a small popping sound is heard while the BSS separates the silicon foils. And no touch zone in the AGB. This is one very important thing that we have to be careful while we're using this implant. This is the area that covers the chamber with the silicone lip plate. So if this is, grasped along the centers, then what happens is it may separate the bulb cover from the implant, can cause a defect in the closure of the bulb, and lead to failure of the bulb due to the adhesions of the bulb membranes. So this is just an AGB video. Nothing much is different from that of the non-bulb implants. The thing is that the conjunctival dissection is less, and then we have to do the priming, and then muscle insertion of the plate in between the muscles are not needed. So hypertensive pace of the AGB. The hypertensive pace are more found to be more common in case of AGB as compared to the non-bulb implant, and it usually starts at 3 to 6 weeks and resolves by 6 to 12 months. It occurs because of the formation of the thick capsules around the plate of the implant. So basically, it goes through 3 post-operative phase. First is the hypotensive phase, that is about POD 3 to 4 weeks. Then hypertensive phase, that is 3 to 6 weeks to 6 months after the surgery. And it is most common in case of AGB, which is considered because of the early fluid drainage, which carries the inflammatory substances that gets exposed, and then the bleb encapsulation occurs earlier. And then later on, it's a stable phase. So what to see in the post-operative period? First is, yes, intraocular pressure, then the anterior chamber, tube position, and then wound architectures. Then in case of bulb implant, pre-operative AGM can be discontinued to prevent the hypotony. In case of non-bulb implants, AGM can be continued except like prostaglandin and pilocarpines can be stopped until the fibrous capsules forms around the plate. And if further IOP lowering is needed, the stent can be removed. So the post-operative medicines involve steroids, cycloplegics, antibiotics, and anti-glaucoma medication. Again, it's based on the surgeon's choice and their practice. So the complications. all the surgeries, especially the GDC, is a very invasive surgery, so it doesn't come without complications. So one of the complications is the corneal complications. Maybe the immediate post-operative hypotony anterior chamber shallowing can cause corneal injury. The tube can cause the corneal injury. And if the tube is not placed properly, then in the long run, it can cause early corneal decompensation. And yes, corneal choroidal detachment and then retinal detachment can occur. And yes, and then bleeding, hypema in the anterior chamber, which is more common with the neovascular glaucoma. And many times it can be blocked with the tube, can be blocked with the vitreous or with the blood. And then yes, diplopia, rare though it is found. And then encysted play in the long run, then tube erosion, tube exposure, and then even plate migrations. So let's look into the newer drainage devices and others. So first we'll discuss about is the Ahmad ClearPath. It is a non-bulb GDD with controlled intrinsic flow designed to combine advantage of barbell type long intraocular control with simpler implantations. It is made up of thin flexible silicone plate. The attempt is made to make the surgical procedure technically easier with a reduced risk of complications. So even a taco technique can be used for inserting because of the flexibility and malleability of the device. It comes in two sizes, and it also comes with a pre-treated 4O polypropylene ripcord sutures and 23 gauge needle. The plate is low-lying and made up of flexible materials and helps allowing easier insertion in patients with a tight orbit or childhood glaucoma with ophthalmos. And one more advantage is the anterior position of the suture fixation eyelet, which allows easier implant fixations without the need for extensive posterior dissections. So Ahmad ClearPath ST, this is most recent version of Ahmad ClearPath GDD, which has come up with certain modifications, like it has a smaller tube lumen that is about 120 micrometer of inner diameter and outer diameter of 457 as compared to 305 and 635 in original SCP. And it also comes with pre-treated ripcord that is 6O proline suture as previously it is 4O proline suture in original SCP, and 25 gauge needle in place of 23 gauge needle. So basically the advantage is it maintains the same plate design but emphasizes on controlling the early resistance with smaller tube lumen and smoother IOP reduction in early post-operative period, more refined control over aqueous flow. So it does not replace the original SCP, but expands the options for SCPs. So next is the Pole implant designed by Professor Pole. It is a bulbless GDD silicone implant. This is silicone implant, so this is easier to implant. It has a surface area of about 342.1 mm square, which is slightly smaller than the barbell glaucoma implant, but slightly larger than the AGB. So the smaller diameter of the tube has certain theoretical advantages that it reduces the area of contact between the tube and the corneal endothelium and hence reduce endothelial cell loss. Extraocular portions of the tube is short. That's why it reduces the long-term risk of tube erosion or exposure and reduce risk of hypotony with no resistance to aqueous flow. So the pole implant has increased AP diameter, so it allows more aqueous drainage, allows the plate to extend further back, and it has a shorter braid, that is wingspan, which reduces the area of plate tucked under the recti muscles, which may theoretically reduce the post-operative risk of strabismus and diplopia. So another interesting GDD device is iWatch implant. It is a novel device in glaucoma surgery, aiming to control the aqueous control flow through an external non-invasive magnetic control unit. It is first adjustable GDD with unique design. So basically, it consists of internal rotating magnetic disc, a deformable silicon tube, and a bearing system, then a nozzle, then an outlet for adjustable flow of the aqueous. So basically, it also has an iWatch pen. So that acts as an external control unit of an iWatch implant. It consists of a compass on one end, which measures the eye watch position, and a magnet on the other end adjusts the opening and closing of the deformable tube. So basically, an eye watch can be set from 0 to 6. 6, that is basically 0 means fully closed, 6 means fully open. So during the intraoperative procedure, most of the time it is being set at 5 to 6, that is basically fully closed or partially open. And in office iWatch, it is office iWatch pen is also used for post-operative clinical use. So another drainage device is an iStent, which is a mix which bypasses the TM and open directly into the Sclam's canal. It comes in a different design. So recent updated versions are the iStent Inject, which has a wider flange, and another one is iStent Infinite, that is third generation standalone. These devices are mainly implanted with the cataract surgery, but iStent Infinite, which comes with the 3 iStents, can be done without the cataract surgery also. Then another instrument is pressure flow. It's a minimal invasive, non-subconjunctival GDD design to lower the IOP by creating controlled blood function as a trabecular alternative. It is composed of poly or called SIPs. It has a biologically inert, so decrease the risk of post-operative episcleral scarring and fibrosis, and hence reduce the risk of early hypotony. So another GDD is an express shunt. It is non-bulb stainless steel microshunt implanted under the scleral plate to divert the aqueous humor from the anterior chamber to subconjunctival space, functioning as a trabeculectomy substitute. So the flow resistance is being determined by the small tube and overlying scleral flap. And it produces trab-like bleb. The advantage is PI is not needed and has a more controlled filtration. Thank you.
Thank you. Thank you, Dr. Tara, for an extensive coverage of glaucoma drainage device. Dr. Vanita, ma'am, comments from you, ma'am.
Yeah, hi. It's all the topics are so vast. It's very difficult to fit it into 30-minute slots, but definitely he's covered everything. The only thing point I wanted to make is I wouldn't put a MIGS in a GDD uh, presentation. MIGS, is a different class of devices, and express device has also been discontinued. So why we are including discontinued devices, I'm not sure. Is this something that is asked in exams?
No, ma'am. Actually, just maybe just
So this
theoretical
is the
part.
third one now where sorry, second presentation now where discontinued devices have been talked about. So yeah, I mean, glaucoma drainage devices are invaluable in refractory glaucomas, as you have said, and it's not just obviously in failed trabs, but there are so many other situations where actually you can even consider as a primary procedure. I mean, I do tubes in really difficult glaucomas like NVG where the angle is closed. Now, when the angle is closed in NVG, I have found trabs don't work very well. Secondly, in uveitic glaucomas. Thirdly, possibly also in ICE syndrome. And I saw you showed a photograph which was actually a patient of mine. I recognize that.
Okay, ma'am.
A tube in the sulcus, and that was an ICE syndrome. And for that particular patient, let me give you the history. When she was referred to me, she had corneal edema and she had very high pressures. And she was referred for both DSEC as well as control of pressure. I always believe that when there is mild corneal edema, when in high pressures, in ICE syndrome, it is likely because the endothelial cells are overwhelmed. They're already compromised and they are overwhelmed. So it is better to control the pressure and then think about DSEC. So this lady actually had clear cornea for 7 years after tube. That same lady. Very recently, she had a DSEC. So one should not be rushing into procedures and take each patient on their presentation, on their merit, so on and so forth. And yeah, they are they help to control IOP in really difficult circumstances. There is no doubt about that. The debate is there whether you should be doing an AGV or whether you should be doing a valve device or a non-valve device. I tend to favor non-valve device much more because I have seen the long-term IOP control mostly without medication. Whereas, with a valve device, minimum 2 drugs, if not 3, are restarted for a patient. And, it is a misnomer when they say hypertensive phase actually subsides by 6 months. Have you actually ever taken a patient off medication because the hypertensive phase has subsided? For the hundreds and hundreds of cases I have done, maybe 2 or 3 I have taken off medication. So with the AGV, I feel, yes, okay, maybe it's safer in eyes which in one-eyed patients who have very advanced glaucoma, and unfortunately that seems to be the the presenting features of most patients that come to me: very advanced glaucoma and one-eyed patients. But when the pressure is very, very high, like in its 50s or 60s on maximum medication, that you will not be able to bring down that pressure for that patient with non-valve devices in the initial period. So then in those circumstances, maybe you do an AGV. I have seen that in private practice. I'm doing, although I favor a non-valve much more, I do a valved a little bit more than, in practice. The other thing is, what I'm really excited about is the smaller tube, the ACP, and I have done a couple, and I'm just waiting for its long-term results. It's only recently been introduced. I'm waiting for its outcomes. What is what is important? I feel most people actually I spoke to in the West who are using smaller tubes say that they don't ligate. But I don't want to convert a non-valve tube into a valved situation, in the sense that aqueous reaching the plate from day 0 and then finding that the bleb encapsulation is huge, and so you are not getting the advantage of a non-valve tube. So I do ligate. I will ligate. And with ligation, of course, it's not just anti-glaucoma medications. You have to use some fenestrations anterior to the ligation, or even use a vicryl stent to help control the pressure in the first 5 to 6 weeks till occlusive suture autolysis occurs. That is also very important. It's not just managing hypotony. The hypotony you're managing with the occlusive suture, okay? But it also is important to manage the initial hypertony, the high pressure, which is what you can do with fenestrating slits or with vicryl stents. And of course, if all this doesn't work, then you can put the patient back on a few anti-glaucoma medications. But of course, with the ripcord in position, again, this becomes safe at the time of suture autolysis, simply because then you don't have such a precipitous drop of intraocular pressure on anti-glaucoma medication, which then prevents choroidals. As we know, we don't want shallowing, we don't want choroidals. So lots of advantages of using a small tube and using a ripcord, and I have been doing that for a very long time.
Thank you, ma'am. Purvi ma'am, your comments ma'am on GDD.
Just for the constraints of time, I'll just be quick. So one is that yes, earlier when these GDDs came into practice, they were primarily indicated for refractive cases. But now, like more and more GDDs are being done for high risk cases where you're almost sure by the seeing at the eye that a trab is going to fail. So silicon filled eyes and UVI takes neovasculars. So there now maybe GDD is the first choice to go. Second, as already seen in the wonderful presentation with very beautiful pictures, that we are still in search of an ideal GDD, because still as we learn through practice, changes are coming up in the surgical techniques, also the steps that we do in the device itself. So because earlier the AGV came, and then the ADI was there, and then the ADI with the ripcord and then venting slits, and now the clear path also, and we are waiting for the poll. So we are still in search of the ideal GDD, just like an ideal mixed device. And just one thing that in the AGV, I think it was mentioned in the presentation that we usually put the patient off drops, but I think it is the other way around, because aqueous suppressants need to be continued for some time, because the aqueous tends to start flowing in the AGV right from the moment you implant, and it is full of inflammatory mediators, which tends to lead to an early encapsulation and an inflamed pleb. So it's advisable that you continue the aqueous suppressants for a couple of weeks before the things settle down, the active inflammation comes down. And then depending on the IOP response and how things go, maybe you can consider weaning them off. So that's just a couple of points.
Thank you, ma'am. We are also joined by Dr. Bhavana Sharma, ma'am. Ma'am, few comments from you before we move to the next talk.
Yes, good morning to you all. And I think it was a wonderful presentation, which was mainly targeting the postgraduates, fellows, and the trainees, and it was well covered. And the comments from Dr. Vanita Patak is well taken, as well as Dr. Purvi. And I think we can move on to the next, that is the trauma presentation.
Okay, ma'am. Thank you. Thank you to all panelists. We'll move to the next speaker, Dr. Charuta Manke. Approaching to a case of ophthalmic trauma, triage in any situation. Over to you, Dr. Charuta.
Can you see my full screen and hear me?
Yes, perfect.
Okay, thank you. Thank you for this opportunity. I am so happy to be on Gurugram. My topic is approach to ophthalmic trauma, triage in any setting. So I think the affiliations did not come. Anyway. So this is what I'm going to cover in this lecture. I will try to keep it to 30 minutes. And if I have some time, I will go to case scenarios. The importance of doing this lecture is for postgraduates especially, is because after doing their MS or diplomas, they will go into various workplaces which may or may not have mentors, or they may or may not have investigations and things like that, or even ER doctors who may want to, who may be may have to treat such patients, and therefore I have taken it as a holistic lecture where anybody, any doctor would be able to triage as soon as an emergency eye injury comes in. So ocular trauma refers to any mechanical, chemical, thermal, or radiation injury affecting the eye or its surrounding structures, ranging from minor corneal abrasions to globe rupture or visual loss. So what is triage? Triage is basically, it comes from a French word to sort, and it has this START method where you have to do a basic evaluation and rapid treatment. So the key aspects of triage are prioritization, especially important in high volume setups like emergency rooms, resource allocation so that you make best use of what you have, and the settings may be in wars, disasters, or busy hospital ERs. And the goal is to treat those who need the treatment immediately in the best possible way and in the right place at the right time. Why should we know it? We have the global burden is quite huge. As you can see, 2.5 million cases of eye injuries annually. Some may be minor, some may be major. Young adults and males are especially injured due to workplace hazards and sports injuries. The impact of ocular trauma is far reaching. It's not only the partial or complete loss of vision, but also psychosocial impact, because they may lose their employment or employment opportunities, and they may also have some mental health issues related to their disabilities. In addition to that, there is an economic burden, because it may be economic burden to the individual, the family, and society at large. So sometimes you are just, you have to see somebody like this. This patient came to us about 2 months ago in an auto rickshaw by himself, and he was a laborer. And looking at him, you sometimes don't know what's happening, what is going to happen, and what the consequences might be. So as we go along, you will realize that that doing everything step by step and having SOPs and having a protocol is very important. Luckily, this person, it was a miraculous injury, and he was, other than sutures on his forehead, it was there was no other functional fallout of it. So the classification of ocular trauma for PGs especially, either it will be closed globe or open globe injury. And in the closed globe, there will be either like a lamellar or a partial tear or a contusion. And in the open globe injury, there will be a penetrating trauma where there is a entry wound. So there could be a retained foreign body, or it could be a perforating injury where there will be a entry as well as an exit wound. So we have to first look at A, B, C, D, E, which we have learned in our MBBS and all throughout. The most important thing is to save life. So if there are any life-threatening injuries, we need to look into that first. So there will be airway, breathing, circulation, disability. Now, disability, everybody may not know the Glasgow Coma scale. So the easy thing would be a AVPU, which is alert, verbal, pain, and responsive. If you can assess this quickly, then it will help you, go a long way with the pupillary responses and glucose levels. And finally, there is something which is E, that is the exposure and environment. That means in chemical burns or in chemical injuries, you need to remove the hazardous clothing or the chemical, and also protect from hypothermia. But the important thing to remember here is that you must maintain the dignity of the patient while doing all of this. Now, the secondary survey is our ophthalmic survey. It goes as 1, 2, 3, 4, 0 being first history taking, which as much as you can from the patient or the relative or whoever has brought them in. Then is the visual acuity at bedside, whatever is possible. The details are in the next slide. External examination will be periorbital, eyelids, orbit, all of that. Then there will be anterior segment, especially initially on the torchlight examination. Pupil we have already looked into. There will be cornea and the anterior segment. And if possible, whatever you can, if there is an indirect ophthalmoscope or any ophthalmoscope, then the posterior segment also should be assessed. So for the students, I would want to say that this is the complete examination in emergency. That is the history, which also includes time since injury, contact lens use, any pre-existing disease, because sometimes when you have to take him for surgery, it is good to have an idea of what else is going on in the body. Visual function, including if you could have a pinhole, then you can check that. Otherwise, you could also just check with light or with your hand movements. Pupillary reactions, that's APD is a red flag. External examination would be the lids, all the adnexa, globe integrity, foreign bodies, and periorbital trauma. Anterior segment would be cornea, conjunctiva, check for hyphema. And in chemical injuries, this will be a red flag, which I will come to specifically, and any classification if appropriate at that time. If possible, we should do a posterior segment examination. If it is not a emergent treatment like a chemical injury, then check at least for the red reflex. And if you have an indirect ophthalmoscope, then go ahead and do the posterior segment evaluation. We should know the ocular trauma scale, and it's easily available. It should be put on the walls of the ER room, so that the junior ophthalmologists also know how to compute, to derive the OTS score, and then we know what the prognosis is going to be, and we can prioritize, especially if there is a mass casualty or if there are junior doctors looking into this. Next, you go, once you have triaged the patient and you know where the patient lies, depending upon what is available and depending upon whether it is immediate care or urgent care or it can be deferred, we should do a complete examination to whatever extent possible. Slit lamp examination to check all the wound details and with staining if necessary, fluorescein staining for abrasions, or to do a Seidl's test. B scan should only be done if no globe rupture is suspected. CT scan of orbit many times necessary for foreign bodies fracture globe integrity. If a CT scan is not available, then you may want to at least do a X-ray to see that there is any radio opaque foreign body. And lastly, MRI, if you think that an optic nerve is involved or a neuropathy, things like that. Secondly, if you have availability of microbiology, if you think that there is some infective etiology going on, then you can do microbiology. Then in the emergency management, we are going to look at closed globe injuries, which also include chemical burns and open globe injuries. So let's look at them. Closed globe injuries, I have covered 4 types. Corneal abrasions or foreign body. First and foremost, when you see that, and if the globe is intact, just remove the foreign body in the best way possible and patch with topical antibiotics, cycloplegics for pain relief, but avoid topical anesthetics because they may delay healing. Chemical injuries are immediate emergency treatment required. Even before assessing, we need to do copious irrigation using normal saline or Ringer's lactate. In absence of these solutions, use clean water, but the most important thing is immediate irrigation. Topical steroids may be used for inflammation control, and then we go on to assess. Look into the fornices and try to remove any particles if you find them. Blunt trauma, blowout fractures, when it happens like a cricket ball injury or any other blunt trauma, you have to assess first and then tell the patient to prevent any nose blowing and give analgesia, give the cold compresses and see for enophthalmos, check all of that because it may not be a immediate, you do not have to do a surgery immediately, so you have time to assess a little bit. For hyphema, again, it is an emergency. You need to use cycloplegics. If it is a closed globe, you need to use cycloplegics and elevate the head. Think about rebleeding. So do not discharge the patient without the appropriate counseling. Monitor for increased IOP. Avoid NSAIDs, and you can use steroids for to reduce inflammation. Now for open globe injuries. In open globe injuries, it's a emergency. Though the surgery can be done within 24 hours, but the assessment and treatment needs to be started immediately. So we must know that we do not want to put any pressure on the eye, try to do any intraocular pressure assessment, no B scans, apply a rigid eye shield or a patch. Check that when the patient has eaten last, so you know that if you need to take up the patient for surgery and the patient needs sedation, you have that ready. Start IV antibiotics and tetanus prophylaxis if no history is available, and then surgical repair. If you suspect an intraocular foreign body, we are going to come to some case scenarios further ahead. Then you can do a CT scan to confirm presence. Nowadays, in most tertiary centers, CT scans, MRIs are available. Avoid MRI if you find history that there was a metallic foreign body. Then you can do a surgical removal. You may, if you have magnets, that will be very useful. To give the complete lecture, I have included some surgical management because although it is triage in any setting, if you have a surgical capability, then you should know what the indications for surgery are. So the primary repair for globe rupture, foreign body removal and vitrectomy when indicated. Now, for the cornea, we need to have an understanding of the anatomy and how the surgery has to be done. Especially when it's linear, it is fairly simple. But when it is triradiate, you need to have a certain training or at least an understanding of it. And therefore, I have included this, but it is beyond the scope of the triage lecture. Now, post-treatment. Why do we need to know this? We need to know this because when we treat the patient and we refer the patient, we need to counsel the patient about what he or she should expect later on, and what the complications may be, because we do not want the patient to be lost for follow-up and then come back with a worse complication. So the late complications can be glaucoma, cataract formation, endophthalmitis, retinal detachment. And for this, we require long-term management. So as I said, psychological support and counseling, sometimes counseling of the relatives or the people who are accompanying the patient or the employers is also required. You need to impress upon them how regular the follow-up should be and when they need to come and why. And you also need to tell them what the prognosis will be, because sometimes the patient comes and you treat and the patient thinks that abhi sab theek ho jayega, but that is not the case. You need to tell them that what the prognosis is, so the expectations are set, and then also explain to them that there may or may not be a long-term visual rehabilitation. So in summary of this, the primary survey needs to be done to prioritize life and then vision saving. The secondary survey will be a detailed eye examination as much as possible in your setting and not leaving out any red flags. Then you should go in for imaging. Maybe if you have an X-ray, then that's good. If you have more, then a CT scan is better, especially to check for foreign bodies and the approach which we want to plan. Then you can refer the patient depending upon what capabilities you have, whether you have a retina surgery or whether you have any surgery or not. In case of emergency management, at the same time, we need to shield the eye, start the antibiotics and avoid pressure. Then you go on to definitive management, which may be various surgical interventions where required, and follow up to monitor for complications like glaucoma or retinal detachments in the future, and disability, as well as betterment of life for the patients involved. So this would give you a complete overview of what triage in ophthalmic trauma would be. So let's look at some cases. There are some typical cases which come to every ophthalmologist, and we learn this in our post-graduation itself. And we could look at it case-wise. Some things may be different. There could be complicated, or some of them may be even combined. Like there could be a metal injury, there could be a hyphema, there could be a lid laceration. So we need to look at each patient as a whole, and again, starting with saving life first. So the 30-year-old man was hammering on a metal pipe without protective glasses. He felt sudden severe pain and blurred vision. And the symptoms were pain, photophobia, tearing, mild nausea. So he had some loss of vision, some conjunctival hemorrhage. Seidl's test was positive. So now you already have a red flag. And then no obvious foreign body was seen externally. So what must you know to ask and see? What would be your triage category? This you need to know. What are your immediate steps before imaging? Which imaging modality should you use? And what most important is when you say do no harm. So you should always know what you should avoid doing. So the important points here would be, this is a high risk mechanism. So assume open globe until proven otherwise, always. Then you put a shield because you've assumed an open globe. You prevent any pressure. You prevent any B-scan, intraocular pressure measurements. You give antiemetics, analgesia, IV antibiotics, and tetanus, and keep the patient fasting. CT orbit to evaluate for intraocular foreign bodies if available, and avoid ultrasound tonometry. We have already covered that. So this would be thing to remember for a metal on metal injury. So for a case 2, splash of cleaning liquid. This we have been hammered into us all throughout our PG, what needs to be done, because this is the immediate treatment required. A 35-year-old worker arrives 10 minutes after alkaline cleaning solution splashed into both his eyes. Symptoms are severe pain and blepharospasm. And on vision, his vision is reduced in both eyes. There was a corneal haze, conjunctiva was white and ischemic. pH strip showed pH 9. If you have a pH strip, you can use it. What must you know? What is the correct triage priority? What is the first management step? How long to irrigate, and what fluid, and what classification scale do you use, if any? So what are the important points? Chemical burns are immediate emergencies. Treat before full assessment. Irrigate immediately without any clean fluid available until the pH normalizes. Recheck pH if available and continue irrigation as needed. Use the Roper Hall or Dua classification after stabilization to continue your treatment. Now case 3, ball injury to the eye and the blow to eye in sports. So what we are seeing here is a 37-year-old bystander who presents after being hit by a cricket ball on the left orbit. So unfortunate. Symptoms were pain, diplopia when looking up, mild nausea. We examined the patient and saw that there was a limitation of upward gaze, though the vision was okay, mild enophthalmos and infraorbital anesthesia, but no signs of globe rupture. So what should we think about here? What type of injury is likely? Is it urgent or immediate? What imaging is needed and why? And what are your priorities here? So what are the important points that you should know? It is a likely orbital floor blowout fracture with muscle entrapment, which you must have suspected. It's urgent but not immediate, so we can take our time to assess and prepare the patient for surgery if required, unless the vital signs are unstable or unless you suspect a ocular compartment syndrome, which again makes it an emergency. CT orbit to confirm fracture or evaluate entrapment, and avoid nose blowing. Counsel the patient, consider antibiotics if required, and refer to oculoplastics if you don't have anyone on hand. Now let's go to the last case here. Case 4, the quiet red eye after trauma. So the history was a 60-year-old woman walked into a door frame yesterday, now has mild discomfort and blurry vision, no major pain. Examination 612, 2 millimeter or full chamber hyphema as it may be, no signs of penetrating injury. IOP was borderline elevated and no pupillary defect of the pupil can be seen. What must you know? Is this immediate or urgent? What are the risk factors for complications? What precautions would you recommend? How frequently should the follow-up be? The important points to note here are, this is not emergent but urgent due to hyphema risk. Rebleeding risk peaks at 24 to 72 hours. This is important to know because we need to know when to call her back, what to be vigilant about, and we need to counsel the patient about the same. Avoid exertion, elevate the head, control pain with non-NSAIDs, and monitor IOP closely, consider cycloplegia if required. In sickle cell patients, so this is important to know, so you can ask this history if the patient knows or take blood for the same. Sickle cell patients require special caution and IOP rise is dangerous. You can also, so these are the 4 major cases that we get regularly for ophthalmic trauma, and it could be a mix and match of any of these or any of the symptoms and signs or any of the visual outcomes. Now, there could be some, I have not covered too many others, but there are some other scenarios to keep in mind, and this could be for your further contemplation. A child with corneal abrasion after finger poke, what would be the triage level and what would be the examination approach? A patient with proptosis and decreased vision after trauma, you should suspect orbital compartment syndrome, and then what would your management be and how urgent would it be? Painless sudden loss after head injury, it could be a traumatic optic atrophy. So what would your management be again, and what would you do for it? Thank you very much.
Thank you. Thank you, Dr. Charita ma'am, for extensively covering the triage part of things, how to approach a case of ophthalmic trauma. Any comments from the panelists?
A very good presentation and a comprehensive coverage. Just a few points to make that triaging is important. So as we see the ocular trauma, it is important that after providing the primary care, the tetanus toxoid vaccination, because most of these cases are having injuries from metallic objects and contaminated biological contamination. So it is important. In addition, there's importance is the documentation. Most of these cases are MLC cases. So documentation at the time of injury is very important, because depending on that, you'll be doing your further management, the surgical and or the medical management. So the detailed documentation. The third is the importance of grading the severity. That is the zone, the type of injury, and the grade, that is the presenting visual acuity is important. All these are very often required in our MLC examinations and for any evidence sort of a thing in court if it goes. And the third is evaluation of the case with reference to the vision, intraocular pressure, and also whether there's any evidence of any infection. So these are 3 most important things which one should look in trauma. Whenever you have got an occult tear or a tear which is not evident, which is not seen, it is important that we evaluate the IOP and also look for any subconjunctival hemorrhage. And these subconjunctival hemorrhage should guide you to whether the patient can be a case of any occult tear in a posterior part of the eye or the posterior, something which is not visualized anteriorly. And yes, the CT scan is preferable in most of the cases, because if there is a suspected foreign body, one might not want to do an MRI in risk of further injury to the foreign body, which could be a metallic foreign body. And it is very important we avoid emergency evisceration in these cases. It is always good to do a repair and abscission of tissues, repair, and of course, counseling to be done regarding the prognosis, and a very good consent should be documented. So these are some points which I would like to make in open globe injury. Thank you.
Thank you, ma'am. Purvi ma'am, your comments, ma'am.
And that was a wonderful and visually rich presentation, Dr. Charutta. So again, for the reiteration for the sake of postgraduates, that these cases, many times they are cases of complex injuries, varied types of injuries, and multi-trauma. So all these triaging is very, very important, because sometimes you can miss one while trying to manage the other. So a thorough analysis of the eye as well as the whole body and the neurological aspect is very, very important. Second is, while the focus, many of the times the focus is like Arjuna, it's just like on one target. So it's very, very necessary to also evaluate the other eye, because sometimes the other eye might be having some visual problems and other pre-existing diseases. And if we ignore that, then later on when the legal things happen, they claim that this was also because of the trauma. So it needs to be clarified from the beginning whether the other eye is normal or it is also having some pathologies, and if anything needs to be done regarding that. And similarly, in follow-up also, the other eye needs to be monitored for the risk of sympathetic ophthalmia, because so that should also be kept in mind, that however a normal looking other eye, at any point of time it may go into ophthalmitis. And again, re-emphasizing what Dr. Bhavna has said, that documentation from the moment the patient comes into the triage area and to the OPD is very, very important. So a thorough documentation of the history, how the injury has happened, the current details of all the findings, the prognosis, and you should also document that the prognosis has been explained to the patient if he or she is in a conscious state, or to the relatives or the attending persons. And the need for multiple interventions, because sometimes these might necessitate more than one surgeries or procedures and have a varied outcome. So all that should not only be verbally explained, but it should also be documented that has been explained. So these findings and paperwork goes a long way in helping out subsequently when the attending surgeon has to appear in court and give all those opinions and everything. And especially if the treating surgeon or the ophthalmologist is not there anymore in the job and somebody else has to vouch for them, that paperwork which is there would be very, very helpful. So that is something which should not be ignored at all.
Thank you. Thank you, ma'am.
Thank you.
Yeah, with that, Dr. Olika, you want to add something, or shall we move to the last speaker?
No, we can move to the
We
last
can
one.
move. Perfect, perfect. So we'll move to the last speaker of the day. If there are no more comments from any of the panelists. Management of open globe injuries. So moving from approaching a case of ophthalmic trauma to managing open globe injuries by Dr. B. Vijay Lakshmi. Over to you, Dr. B. Vijay Lakshmi, for your talk on managing the globe injuries. You're on mute, madam. You're on mute.
Can you hear me now?
Yeah, perfect.
Yeah.
Perfect. Yeah.
Good afternoon, everyone. Thank you for this opportunity. I think my talk has been given a very good introduction because of the previous speaker and the discussion which has taken place before. So we are on the right track. I would be concentrating on the management of open globe injuries, but as rightly pointed out by the discussions before, I just go 1 minute.
If you click on the slide, it will move forward. Yeah.
My agenda would be to how to approach a patient with trauma. Just a brief note on classification of injuries, which is very important because before managing, you should know what you're dealing with. and we'll deal with few case-based scenarios and do's and don'ts in trauma patient and follow up how do we do in a trauma patient. So this is a typical patient who comes to you in a eye emergency. This was a patient we have seen at Sarojini Devi Eye Hospital, Hyderabad. So this patient had this big bandage and he had come with a lip tear, and we could not visualize anything inside. The point I put out this photo is it is very important to see the patient in toto. This was the injury he had on that underneath that bandage. So it is very important that when the patient comes to us, he must have got a primary primary treatment somewhere or primary first aid somewhere, and he would come. And it is very important for us to look at the patient as a whole and not just the eye itself. So life-threatening and limb-threatening injuries are always a priority. What all you have to ask when you are seeing a patient like this, first always note whether there was any history of loss of consciousness, whether there is any history of nasal bleeding, ear bleeding. These are alarming signs. These things need more importance than the eye treatment itself. Injuries to the limbs, blunt or penetrating trauma to the abdomen and the lungs, and injury to the head. All these things have to be noted, and these have more priority over the ocular trauma. What all do you have to note whenever a patient comes to you with an ocular trauma? What is the mechanism of injury? Usually when we see in ocular trauma patient, if we are not used to seeing such patients, there is a little bit of panicky thing and we don't know what to do. It's very simple. We should not forget our basics. The history taking is very, very important. The history taking has to be meticulous, and you have to concentrate on the mechanism of injury. What is the timing of the injury? And what is the mechanism of the injury, whether you are suspecting an IOFB in such sort of an injury, what is the past medical history of the patient, is he on any drugs, is he having any other chronic diseases, any history of previous ocular surgeries, current ocular and systemic medications have to be listed down, and also vision in both the eyes prior to the injury. Most of these are medical legal cases, as the discussants have previously pointed out, and it is very important to note it down in the history itself. How was the vision according to the patient prior to the injury? And also the tetanus toxoid status. According to the BETS terminology, we have open globe injuries and closed globe injury. So whenever there is a breach in the cornea and sclera, we call it as an open globe injury. Whenever there is a blunt trauma causing an open globe injury, we call it as a rupture. Whenever it's a sharp object, we call it as a laceration. Usually it has been seen that these perforating, penetrating, and these terms are used interchangeably, but it is preferable not to use them interchangeably. Penetrating injury is something which just has a entry wound. Perforating is something which is having an entry and exit wound. So you have to mention in your case sheet what type of open globe injury it is, whether it's a rupture, penetrating injury, intraocular foreign body, perforating, or a mixed mechanism injury. Also, you have to note about the zone of the injury, whether it is zone 1, which is just located up to the limbus. Zone 2 is anything from the limbus to 5 mm. Anything beyond is zone 2. Grade of the injury based on the visual acuity is also important to be assessed, where you grade from when it is more than 20 by 40 vision, you grade it as grade 1, to no PL as a grade 5. Also see the pupil, whether there is an RAPD or not, which is very important in prognosticating. So always check for the intactness of the cornea and sclera, and so that you can classify it into a closed globe or an open globe injury. So closed globe injuries are superficial injuries where the cornea and sclera are intact. Open globe injuries are the injuries where there is breach in these two layers. Good management always starts with taking a good history taking. You cannot do a good justice to the patient without taking this if you avoid this step. You have to ask about mode, duration, time, and object of the injury, associated systemic injury, medication and intervention done after the injury, and possibility of globe perforation, posterior scleral rupture, intraocular foreign body, and concomitant microbial contamination has to be in your mind. These cases also have medico-legal implications. So you writing the history properly and documenting properly is very important, because sometimes these cases go to the court 4 or 5 years after the injury has happened. And then what is written on the document is the primary evidence. Always examine both the eyes. This is very, very important. And initially check the visual acuity, do a diffuse torchlight examination to check if there is any surrounding lid trauma, or if there is any orbital trauma or any enophthalmos. You can check for the extraocular movements, you can palpate the orbital margins, check for the consensual light reflex, and take the patient up for slit lamp examination. What are the usual presentations? Though lamellar tear doesn't come under, I have included this because this is how a lamellar corneal tear looks, where it is not full thickness, where the tear is restricted to certain thickness and the AC is very well formed. So in some cases, you can just get away with doing putting a bandage contact lens. But if you feel that the lamella, the tear will not heal properly, you can put sutures for it. The other type of tears where you usually see is a small tear here, which is at the limbus here, and the AC is very well formed. As you can see, there is a foreign body adherent in the lying in the tear. Or sometimes you come across these large tears with iris prolapse, or there is a limbus to limbus tear with tissue loss and also flat anterior chambers. It is very important for us to look at the patient carefully. This was a 70-year-old patient with blunt trauma. If you look at it, the cornea looks okay. This part of the sclera also looks okay. Just lift the upper lid and you will see that there is an underlying IOL lying subconjunctivally. So this is probably a case where a previous SICS section was opened because of the trauma, and the lens has been dislocated into the subconjunctival space. So lifting up the lid and seeing the patient completely is very, very important. Now, this was a case of a 60-year-old female with a bullhorn injury. In this case also, there was a bullous subconjunctival hemorrhage, for which whenever there is a doubt, whenever there is a bullous subconjunctival hemorrhage and you are not sure whether there is a wound or not, it's always better to take up the patient for wound exploration. So this patient had, on examining, what we found was, in this patient there was a temporal SICS incision, and this incision had gaped. So doing that, having high suspicion is very important. Even if you open up a suspicious wound and you find out that everything is intact is okay, but missing a wound is not okay. So what are the common sites of perforation? Usually the limbus, previous incision sites just behind the extraocular muscle insertions, scleral tunnel as in SICS, or near the exit of the vortex veins. What are the key investigations you do? First, always, if you have an X-ray, that's good. Then if you are suspecting an intraocular foreign body, you can go ahead with a CT scan. Preferably avoid MRI when you are suspecting a metallic foreign body. You can do a gentle B scan if you think that you are trained enough to do a very gentle B scan and you will not cause more damage to the eye. If you are in doubt, if you think you are not capable of doing a gentle B scan, you can defer it to the post-operative time. Also, if you feel that sometimes the patient don't come immediately after the wound, they come after few days, and if you feel that there is some amount of infection lingering around, you can send the tissues for, you can scrape the edges, you can scrape, and also you can send the tissues for microbiology. If you find out any intraocular foreign body in the anterior chamber and you think that it is infected, please place it in a culture plate and then send it for microbiology. What is the pre-op management? Admit the patient, always make an MLC, place an eye shield, antiemetics and analgesics, IV antibiotics have to be started. And tetanus toxoid, if it was not given, then give them a booster dose. And for GA, if you are planning under GA because of uncooperative patient or because the patient is a child, then you can put the patient on NBM. What is the aim of corneal wound repair? The primary aim is mainly to achieve a complete watertight closure of the wound with restoration of the structural integrity. The secondary aim is to avoid damage to the lens and the other tissues. Tertiary aim is actually to give visual improvement and minimize post-operative astigmatism. So if we go ahead with the case scenarios, this is a case of a lamellar corneal tear. Now you see that the AC is very well formed. It's like a LASIK, it's just looking like a LASIK flap. It is not a LASIK flap, it's similar to that. But in such cases, what I would preferably do is just put stay sutures so that the healing is complete. Some people get away with doing just a BCL also in such cases. It is important to note that in these cases, it is very important to note that sometimes in these areas of the limbus, there might be a deep, deeper depth of injury where it might be full thickness. So it's very important to take the patient up and then see under the microscope thoroughly. And then it's not a crime to put a suture. So it's better you put a suture, but it is a crime to miss a wound. So this is the test which all the postgraduates should be very familiar with. So this is a video of a Seedles test. This is nothing but just showing you dilution of the fluorescein with the aqueous. This is what you have to see whenever you are seeing a wound. And whenever this is positive, it's called as a Seedles positive. Sometimes it is positive when you gently press with the lid on the wound. So that's a force Seedles. So these two tests you should be very thorough, and because you will decide whether you have to take the patient up for management, or you will this is a closed globe injury will be decided based on this test. So as I told you, please rule out any occult perforation. Whenever there is a suspicion of an occult perforation, you can do a force Seedles test. Your primary goal should be reepithelialization and stromal healing, prevention of infection, and then focus on reducing the corneal irregularity and minimize the corneal scarring. So when you are having a corneal lamellar tear like this, either you can place a soft bandage contact lens or you can place sutures. For a full thickness corneal tear, whenever you are taking a patient up for corneal tear, it's important that you don't give massage. You give a careful, gentle block so that you are not expelling off the tissues outside. If you are not having very experienced nurses, it's a very good idea to put the speculum under the microscope all by yourself so that you don't avoid extra damage to the tissues, which is the wound is already open, the eye is already open. So it's very important that you avoid unnecessary damage. So when you are putting the sutures, few things you have to remember. Every suture you put has a diamond area of zone of compression. Whenever you are putting the sutures, it is advisable that this zone of compression, which is an invisible, it is not visible, but it is what you experience after you do few sutures. This zone of compressions between the two sutures should be overlapping. If the zone of compressions are not overlapping, then you will find a gap. So whenever you are putting sutures, you have to put as many sutures so that the zone of compression of the sutures. So the longer the sutures, the larger will be the zone of compression, but more will be the astigmatism. The shorter the sutures, the small will be the zone of compressions, and you will require more and more number of sutures. So you have to titrate yourself between between the length of the sutures and the number of sutures. Now, this Ravse hair technique of suturing is very, very important whenever you have a limbus to limbus corneal tear, where they say that whenever you are suturing in the pupillary axis, you put shorter sutures, and whenever you are going towards the limbus, you put longer sutures. Always, whenever you're taking a bite for the suture, your needle has to enter perpendicularly, and you have to go 90% depth. You have to go 90% depth. Do not touch the edges of the tissues, and you can do either a 2-1-1 or a 3-1-1 type of suturing. And it's very important that as you are learning the technique of suturing, it is important that you have to learn the technique of knot burying. It's simple. If you put adequate length of the suture, you just have to catch it away from the knot and just move the suture with a non-tooth forceps, and you will see that the knot is just going underneath the surface. It is important to bury the knots because exposed knots are a constant source of irritation and also a nidus for infection. So as I told you, 90% of the corneal depth should be the depth of your suturing. If you have 100%, why don't you do it for 100%? Because it becomes a track for infection if there is any. And if it's very superficial, you will see that whenever you are putting a superficial suture, you will see that the iris will come again and fix up in the remaining part of the gaped wound. So that is not what we want. Regarding the tightness of the sutures, it's very important that you have sutures which are equally tight. If you have extra tight suture in one place, there might be gaping opposite to that. So the tightness of this, if you feel that the suture is very tight, please remove it. Then again titrate the tightness of the suture and keep it. And it's always important that you put one suture here. If it's a circular wound like this, then put it in opposite so that you have equal traction. Whenever you have a triangular flaps, it is very important that you have to put one suture at the apex always. This suture, unless you put this thing, it will not heal. And one more thing you have to remember, this is like whenever there is a triangular flap, this will be like an elevated flap. So your first bite should be from this side to this side. If you take it in the reverse way, you will not achieve wound closure properly. This is a short video of just showing the showing a corneal tear repair. So this was a 14-year-old school girl who had injury with her spectacles. So the first suture we are taking at the limbus. So we are not touching the edges of the wound. So sometimes you will have to replace your sutures, the first initial sutures which you are putting, because we are putting them in a relatively open wound. So if we are not happy with the tightness and the position of it, you can always remove it. And the second suture is put at the other end of the wound. Then you put the third suture in the middle. It's important that we make sure that there is no iris in the wound. So for that, we will put a side put and we'll inject visco and sweep off the, like visco is getting injected, and with the help of iris depositor, we'll sweep it underneath just to make sure that there is no iris in the wound. Because iris will impair healing and there will always be a wound gap whenever there is iris in the wound. So you'll fill up the remaining gap with the sutures. It's important that the sutures are perpendicular to the wound. Sorry. And the number of sutures should be done, and the direction of sutures should be individualized. The way I do this wound need not be the same way I do every other wound. So every wound is like a new test paper for me. So every wound you have to see it individually, and you have to give a customized treatment where I should take the first bite, how I should take, whether I should take it from the left side to right side or right side to left side, will all depend upon the configuration of the wound. So seeing that individually is very important. If you try to go for a blanket treatment, you will fall into trouble. Also, whenever you have wounds which are very close to the limbus, it is very important that you open up the conjunctiva, see to what extent that wound is there. And near the limbus, if it is 1 to 2 mm, you can do with your 10-0 nylon sutures. But otherwise, when it is beyond that, you have to go for either 7-0 Vicryl. Can cover up the conjunctiva also after this. So as I told you, it's always important to release the iris from the wound, and the iris abscission is usually done whenever we are unsure of its healthiness, and whenever sometimes visibly we can make out that the iris is the color has changed and it is not healthy. So then more than 48 hours is when we remove it off. Coming to the lacerations with damage of the lens. Cataract is one very important thing which is very fascinating for all the postgraduates. So seeing a total cataract which you always operate in your unit postings might be very tempting, but primary lens aspiration is not the solution in cases of open globe injuries. It's better only in few conditions we do primary lens aspiration, but in many conditions we try to do a secondary cataract with an IOL implantation. Now, this is a case where the patient had a injury with a thorn. So, if you can see, the wound is somewhere here, and there is a there's a small wound, and there is a rupture of the anterior lens capsule with a lot of lens matter in the AC. In this sort of wound, you can do the primary lens matter aspiration. But IOL implantation is not done at this point because we never know whether this patient will have infection or not. So secondary IOL implantation is always better. How much ever tempting, how much ever good surgeon you are, even though you have preserved the posterior capsule, it's better to defer the IOL implantation for the first sitting and do it in the later sitting after 4 to 6 weeks. So indications for the primary lens aspiration is mainly when the lens matter is in the AC, where there is an injured lens capsule, or when there is an IOFB you have to handle, which is supposed to be very immediate, or where there is complete dislocation of the lens into the AC. The disadvantages of doing a primary lens aspiration is there is poor view, because sometimes there is a lot of hyphema. You don't know what is the status of the posterior capsule. You will be, and there might be, you will not be able to get the accurate biometry, and you will be increasing the posterior capsular rents which are pre-existing if they are because of the trauma. Secondary cataract removal is the procedure of choice other than those 3 conditions which I have told you, because here you control the inflammation, you make the eye quiet, and then you get a proper biometry done, and then you go for an IOL implantation. Now this is another case where there is a limbus to limbus corneal tear which is extending beyond the sclera. So in this case, again, we'll put the first suture at this limbus, second suture at the other limbus. So the second suture at the other limbus, and then we'll first finish off the corneal sutures by putting it equal, like we'll divide it into halves and we'll keep on doing it, and then we'll finish off the corneal part. After that, the scleral part is slowly extended, and then sclera is sutured. This part you can probably do with 10-0 nylon. The remaining part you probably have to do with 7-0 Vicryl. So suturing sequence, just to show, first suture is always at the limbus, second suture is at the other end of the wound, the third suture is in the middle, and then you divide it into equal halves and go ahead continuously. For the sclera, you go ahead one by one, and as you go, you keep on exposing the wound and you suture the sclera. Postoperative management usually consists of systemic broad spectrum antibiotics, analgesics. Sometimes if you are suspecting pan-off or end-off, you'll go for IV antibiotics, and then you give topical antibiotics, cycloplegics, and steroids. You might have to defer steroids if you are suspecting infection of your wound. So withhold the steroids for 2 to 3 days and then keep the patient admitted. Then see the patient after 2 to 3 days. By that time, if you are sending any offending agent for culture, you will get your preliminary culture report, and then you will take the patient for, you will start the patient on steroids. In the follow-up, it is very important that you check up for the visual acuity, and always check the normal eye. It has to be screened for sympathetic ophthalmia. This is very, very important. And also do a detailed fundus evaluation. Loose suture in any visit has to be removed. So if you see a loose suture in the first week, then you have to remove it and resuture it. Anything beyond 6 weeks, probably you have to see the integrity of the wound. After 2 months only, you need not resuture the wound. Anything before 8 weeks, you have to check. Within the first month, always better to resuture. The visual rehabilitation will be later with the help of a optical PK or IOL if they have a central corneal scar. The complications of these open globe injuries may be endophthalmitis, traumatic cataracts, glaucoma, choroidal ruptures, retinal detachment, and crisis bulbi. The prognosis is very important. Most of the patients, how many ever times you tell, they are in a denial mode and they generally don't understand this. But as doctors, it is your duty to tell them multiple times that their prognosis is always guarded, and good prognostic factors usually include good visual acuity at presentations, lacerations anterior to the rectus muscle insertions, absence of any lens damage, and no intraocular foreign body. It's always better to under promise and over deliver, and always give a guarded visual prognosis only to your trauma patients. Ocular trauma score, this is very important, highlighted by the previous speaker also, which will help you to tell reasonably to know whether this patient, how the prognosis of the vision will be. Now if you see a few cases, this was a case of small limbal tear this patient had with a foreign body impacted in the tear. So this was a right eye open globe injury, zone 1 type C, grade 1 and pupil negative. This was the foreign body which was removed from that. And we actually sutured the limbal tear with 10-0 nylon sutures, and the patient had good vision post-operatively. This was another case where the patient had a small entry wound and there was this stone foreign body. He was hitting stones and there was an intralenticular stone. So this patient, we had sutured the wound and we had done a primary lens aspiration. We deferred putting the IOL, though the PC was intact. This patient, we had put the IOL after 6 weeks and he regained a vision of 6/9. So this is another thing just to tell that, do I have time?
Yes, ma'am. Please go ahead.
Yeah.
Yes, ma'am, you do.
Yes. So this video I just put just to tell that each wound is different. Now, if you see this wound edges are all elevated. So you have to decide, you have to take your sutures like this from this side, from the limbus to the cornea. So each wound, each particular suture has to be individually titrated so that the wound apposition is complete. All of these cases need long-term follow-up and comprehensive eye examination is mandatory in all the follow-up visits. To summarize, it is important to differentiate between open and closed globe injuries. Prompt early treatment is crucial in restoring the vision. Long-term follow-up of these cases is very much necessary and a comprehensive complete eye examination is must in follow-ups. And it is important to prognosticate regarding the long-term follow-ups, need for multiple surgeries and the visual potential. Thank you. These are the few pictures I had put. So most of the times when we don't see a lot of ocular trauma patients, what we think is whenever a patient has a corneal tear, his vision is gone. But these are my patients of 3 different patients who actually came early, very early after the injury. And luckily they got very good vision. This patient was unaided 6'6" and this patient was around 6'12" and this patient was also around 6'6". So having an ocular trauma is not the end of the world. Handling it properly in the first go is very, very important. Thank you.
Thank you, ma'am, for the excellent illustrations and how to go about suturing, especially for young ophthalmologist. With that, we'll open the forum for a panel discussion. Dr. Bhavna, ma'am, your comments, ma'am.
Yes, it was indeed a very comprehensive and a well-covered topic, and it is one of the very frequently encountered clinical entities which are residents and fellowship trainers and all these come across during the years of the training. So it is very apt to understand all the principles of management, the complications, and what would be the prognostication of such cases. One thing which I would like to comment here is there was a mention about the lamellar corneal tears. So the indications for lamellar corneal tear remain that it is at the 1/3 depth. Once you see on the slit lamp, if it is at the 1/3 depth or more, you have to repair it. Even if the approximation you may see. The second is that there is a flap which has been created. So flap has to be deposited and then has to be sutured. And the third is that these are the cases where serial test becomes very important. There may be some micro leaks which may not be evident because of the seal tear and you may not know at the slit lamp. So it is good that you do a serial test at that time and to suture these wounds. It is also important to place the sutures equidistant and equidistant, that means the length of the sutures are very important so that the zone of compression is overlapping between the two sutures. And the Rouse-Hayes technique is very good technique which guides us through a well done corneal tear with minimum astigmatism and topographical changes. So I think those are the important points which have been covered already. And we have got a book on corneal emergencies, which we have very comprehensively covered management of lacerating wounds. So one can refer that also. I could see a few pictures from that book was there. So thank you. And it was indeed a very good presentation.
Thank you. Thank you, ma'am. Purvi, ma'am, your comments, ma'am.
Yeah, again, a wonderful presentation, and especially I liked those details and slides on suturing, because that is something which is not very frequently covered in talks and webinars and discussions. And we just incidentally happened to have a brief talk on this, Dr. Rolika, about the suturing aspect. So this is very, very useful, because sometimes all the students, no matter what the surgery, what the tissue, they tend to take the similar type of sutures everywhere. And then they, tend to overlook like the effect on astigmatism, that could be cheese wiring, and as you said, iris becoming adherent to that wound area. So changing the suturing technique, the length, the depth, and everything it matters a lot and which needs to be definitely kept in mind. So,
Thank you, ma'am.
thank you.
We are also joined by Dr. Satyan sir. Sir, we did discuss about trabeculectomy, mix, GDD, and we are just ending the session with a bit of trauma. You're free to add your comments on any one of the above, sir.
I'm sorry I couldn't join for just went for an emergency. Both the topics were quite important and just a clinical relevance as well as the relevance for the patient. Just wanted to give you some information on we all know what is called as a target IOP. Mild, moderate, severe disease, we have the target IOP. And the medical management of glaucoma, we have the target IOP of, say, for example, advanced glaucoma, we have 10 to 12, something like that. But when you do the trabeculectomy, what is important is the IOP fluctuations are very much blunted. Even if the IOPs are slightly on the higher side, that doesn't mean the 20 plus. Say, for example, advanced glaucoma IOP is, we say, about, say, 12. But even if it is like 15, 16 post trabeculectomy, the progression is not much seen post trabeculectomy. This is important information that we should know. The fluctuations are one of the reasons for progression of the disease. So understanding and doing a proper trabeculectomy, especially in our own population, because we know that the compliance is one of the major risk factors in progression of the disease. You also remember, Prasanna, how good
Yes,
is
sir.
our compliance in our patients. So by 1 year, only 50% or even lesser patients only will be applying the drops properly. So understanding and how to do trabeculectomy is very, very essential in our own population. So everybody must know, at least in our, whenever you're doing your PG or even post PG also, try to learn the trabeculectomy, which is a wonderful surgery. It is not that difficult to learn when you can do a phacoemulsification. So better we learn the trabeculectomy so the eyes can be saved throughout the patient's lifetime reasonably well. I'm not saying that every patient we can save, but when you do the trabeculectomy properly and also the tubes, we shouldn't hesitate in going in for the tubes. Even if you don't know how to do the tubes or traps, when you feel there is a increase in the progression, then it is better either you do the trabeculectomy or whenever there is a need for the tube, you must send the reference to your colleagues who can do a proper trap or a tube. So doing a trap and tube is very, very important. And also we can save the patient's sight throughout their lifetime reasonably well. Otherwise, medications, poor compliance, these patients are going to lose their eyesight in their lifetime. So we must be careful about that. So essentially in our patients, the glaucoma management is more or less like the surgical options most of the times. Only thing is we don't do, so that's why we are kind of restricting in our surgical. But once you put more and more medications, the surgical success also becomes poorer. 4 medications, 5 medications, it is not a good idea to go for 4 or 5 medications. Only when there is no other go, you go for more than 2 medications. But when you have the choice, better not to cross more than 2 medications to achieve a target intraocular pressures.
Thank you, Satyan
Thank
sir,
you.
for chipping in.
Thank you, Prasanna, because I just chipped in very late. It was
That's
an
okay,
emergency
sir.
that I have to be there. Yeah.
Yeah,
Thank
That's
you.
absolutely fine, sir.
Yeah.
Thank you for still joining in, sir. That also means a lot to us.
Yeah. Thank you. Thank you so much.
Yes, sir.
So,
Any other comments from any of our panelists or faculty? I think we have
yeah.
covered everything, Rolika. I think we
Yeah,
are.
I think I would just say that a lot of residents are texting me right away. Like, then they are able to understand certain basic techniques. A lot of residents mentioned, I mean, I wouldn't say a lot, like three of them messaged me. They actually told me that they wouldn't think about the techniques of suturing this way, and how ma'am mentioned about how the periphery should be longer and the center part should be shorter in the pupillary axis. These are things that they did not think about or they did not know about. And now that they have the good references, they're going to go and look at those references and learn about these techniques. So I think the very fact that all of you who have come across over here and shared your experiences from great colleges, and then the residents from every college, they're able to see and learn from you all. That's a platform that we wanted to create. And I'm glad that we are able to do that. And we are glad that we are able to convey it to postgraduates and ophthalmologists, general ophthalmologists, and early on ophthalmologists in the career. So thank
Yeah,
you,
just
everyone.
one
Yes,
word.
sir.
Actually, we are quite eager to teach the trabeculectomy. May not be the tubes, but the trabeculectomy part of it, we will be kind of actively involving ourselves from the GSI, as well as so we would be happy to associate with the AAYs also to
Sure.
take it to the next level so that more people can learn trabeculectomy, especially the developing countries like India or the underdeveloped countries. More so, we need the trabeculectomy because the patient's compliance is quite poor, actually. So we'll be
Yes.
actively doing this. We'll have to see how best we can do so that more people can be trained in doing the trabeculectomy basics.
And I do have one comment which a resident mentioned, and I think you all will be happy to hear that. They said that I always thought that going for international fellowships is going to help me learn more about surgeries. But seeing today, the Indian speakers, I've realized that we have more in India. So that is so true. Yes, that is absolutely right. You cannot get the clinical hands-on or clinical surgical experience anywhere else, but people come to India. So take your surgical experience here, and we have great teachers, and you can always go to the other countries after doing your initial fellowships, and that will be like a supplement on what you have learned. And that's also a very good thing, because then you get a different perspective and add on to your current techniques. So thank you so much. And with that, I'll also thank Dr. Prasanna for co-moderating the session with me. Thank you so much for always being there. Thank you, everyone, and have a wonderful Sunday. And looking forward to meeting you all in person.
Thank you so much.
Thank you.
Have a wonderful
Thank
day
you.
ahead. Thank
We'll
you.
have a quick
Thank you.
photograph. All of
Yeah, yeah.
Ma'am and sirs, we'll have a quick photograph.
Go ahead, take a screenshot.
Yeah.
Yeah,
Thank
sure.
you.
3, 2, 1. Cheers.
Okay.
Done.
Thank
All
you.
right. Have a
Thank
great day,
you.
everyone. Thank
Yeah,
you so
all of
much.
you. Thank you.
Thank you,
Have a
ma'am.
wonderful day ahead.
Thank you, sir.
Thank you.
Yeah.
you.
Bye bye.
Thank you.
Thank you, Bhavna ma'am. Even I know that you were traveling too. Thank you so much.
Thank you. Thank you. Bye bye. Thank you.
Thank you, Satya.